Okay, good afternoon, everyone. Welcome to today's North American Summit on the impact of the COVID-19 pandemic on addiction. My name is James Mckellap. I'm the director of the Peter Boris Center for Addictions Research here at McMaster University and St. Joseph's Healthcare Hamilton. It's my pleasure to welcome you today. And I'd like to start with a land acknowledgement. We recognize and acknowledge that many of us today are meeting and learning on the traditional territories of the Mississauga and Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum, an agreement to peaceably share and care for the resources around the Great Lakes. I really want to thank my co-host today, Dr. John Kelly, the director of the Recovery Research Institute at Massachusetts General Hospital and Harvard Medical School. It's a real privilege to be able to do this together and I think take on what is a really important issue. I want to thank Dr. George Koob and our other speakers today, and also thank Hazel Simpson and Alan Fine for all their help in organizing the event today, which has been essential. I will handle some housekeeping things to start with, so everybody knows. It's COVID and we're on Zoom, so there'll be technical difficulties at some point, hopefully not many, and hopefully not to start, but it may happen. Everything will be recorded and archived and available on the RRI channel on YouTube, if you're interested in the future. Some of our speakers are live today, others are pre-recorded. Questions for live speakers will be handled by a moderator at the end of their talk in order to make sure that we stay on time. But the overall question and answer period at the end will permit people to speak directly to each other and to John and myself. We will take regular bio breaks for over the course of the afternoon. And just to offer a couple of thoughts in advance, why put together a summit on COVID-19 and addiction? And really, John and I started talking about this because we thought about just how much had changed over the last 2 years. And it's hard even to imagine March 2020 now. The scope of the pandemic has been so vast, and it's hard to imagine nearly 500 million cases globally, 6 million deaths at this point, nearly 1 million in the US alone. And the burden has been so much more than just an infectious disease burden. We know that this is reverberated across medicine and healthcare, especially in psychiatry and especially for individuals with substance use disorders. The pandemic period has also been a time when science has really had to meet the moment and respond in real time. And in some ways, it's been miraculous with the development of tests, novel surveillance systems, and indeed multiple safe and effective vaccines developed in record time. And there have been tireless and inspiring examples across science. But many of us have also been working in the trenches and focusing very much on adapting our research projects, addressing patient needs, and really keeping our nose to the grindstone. So John and I thought this would be an opportune time to move from the trenches up to a 1,000-foot perspective to try to get some perspective, to take stock of what we know and what we don't know. Our hope was in part that the pandemic would be somewhat in the rearview mirror, but the Omicron variant really demonstrated that whenever you make a plan, COVID has another one. And the reality is that the impacts of the last 2 years will continue to have ramifications and reverberations for a number of years to come at the very least. So more than anything, the goal was to reflect on what we know and what we can learn from what we know in order to ultimately better understand addiction and care for individuals who struggle with substance use disorders. Let me pass the microphone to John to offer some additional opening remarks.
Thank you, James. I hope everybody can hear me okay. Good afternoon, welcome. I'm Dr. John Kelly, and very happy to be here with you all. Thank you for joining. James, thank you for opening things up, and thanks for your leadership here in this area and collaboration. It's just such a joy to work with you on this and many things that we've done together. But yeah, as you said, James, here we are 2 years on, almost exactly to when the initial restrictions came down roughly on St. Patrick's Day last 22 years ago. And none of us thought, could imagine what was coming, given the rarity of these worldwide events in the history of humankind, as far as recorded history goes, and the gravity, the gravity of the situation that we have all faced in the last 2 years. You may recall when I was just reflecting, thinking back to watching the news, everybody was talking about hand washing. Remember, right at the beginning, that was going to be enough. We're just wash your hands, make sure you wash your hands, and this thing will be over by Easter. Remember, that was the hope, of course, in way back when, 2 years ago now. Seems like a long time ago, doesn't it? And here we are still. Hopefully, we said this before, of course, but hopefully this thing is in the rear view mirror regarding the epidemic aspects of it. And we are dealing now, as many people tell us, with a more endemic situation, similar to other kinds of viruses that may be going around the planet that we'll have to contend with on an ongoing basis. But we're here, of course, because of the impact this has had on addiction, substance use disorder, and substance use, both in terms of its clinical course, its development, and its treatment and recovery from it. And we're just so thrilled that we've got such a star-studded panel of top world experts here. This, of course, is spanning two nations, both the nation of Canada and the United States represented. We've got the head of the National Institute of Alcohol Abuse and Alcoholism, Dr. George Koob. We have the head of the National Institute of Drug Abuse, Dr. Nora Volkow from the United States. We've got Dr. Miriam Delphin-Ripmon, the head of SAMHSA, here with us. We have Dr. Rita Notarandrea from Canada, as well as our own panelist and co-host, Dr. James Mckellap, who will also be highlighting many things we've learned clinically. So just an amazing panel. Thank you to all the panelists who've given up their time to come and contribute to the proceedings, which I think are going to be just a tour de force of overview of what we've learned and what we can do in the future. This, of course, is being recorded, so it will be able to be viewed after our proceedings here today. So thanks, everybody, for coming. And I'll hand it back now to Dr. Mckellap to introduce Dr. Koob.
Thank you, John. Dr. George Koob is an internationally recognized expert on alcohol and stress and the neurobiology of alcohol and drug addiction. He's the director of the National Institute on Alcohol Abuse and Alcoholism, NIAAA, where he provides leadership in the national effort to reduce the public health burden associated with alcohol misuse. As NIAAA director, Dr. Koob oversees a broad portfolio of alcohol research ranging from basic science to epidemiology, diagnostics, prevention, and treatment. He is the preeminent thought leader on alcohol and health, from biology to behavior to policy. Please join me in welcoming Dr. George Koob.
Thanks, James, and thank you, John, for both of you for inviting me to be part of this. I'm really looking forward to the rest of the symposium. So my subtitle here is Learning from the Pandemic and Looking Ahead to the Future. What I plan on covering today is I'm going to talk about before COVID-19, a little bit about the landscape of alcohol misuse in the United States. And then I'll talk about COVID-19 and alcohol. And I'm going to revisit our earlier framework and explain where we see what has transpired over the last 2 years. So I'll talk about the biological and behavioral effects of alcohol, the impact of the pandemic on stress and mental health, the impact of the pandemic on alcohol drinking and harms. I'll go through some details from sales, survey, hospital, and national data, and then the impact of the pandemic on alcohol use disorder treatment and recovery, and some really positive news there, which is the promise of telehealth, and then promoting wellness to reduce alcohol misuse, and just some early thoughts on strategies to manage stress and enhance resilience. So before COVID-19, alcohol-related deaths in the United States were going up. They basically have doubled in the last 20 years. Death rates were highest among men and middle-aged and older adults. Death rates increased over time across all age groups except 16 to 20 and 75 and older, and the increase in death rate over time was greater in women than in men. And these statistics align with recent reports that have highlighted changing trends in drinking patterns and increased consequences of alcohol in women and the aging population. But one of the things that we also noticed is that it was the seminal work of Anne Case and Angus Deaton, which are shown in the little slide figure on the right. And that is that alcohol plays a prominent role in the deaths of despair. Three of the major areas that they identified as contributing to increased mortality originally in white non-Hispanics was poisoning, suicides, and chronic liver disease. And alcohol plays about 15 to 20% a role in all drug overdoses, about a quarter of suicides, and half of liver disease deaths in the United States. And so these deaths of despair contribute to the decreasing life expectancy in the United States since 2014. And despite these original observations in this particular subgroup, the patterns of increased mortality have also been now observed across many racial and ethnic groups and age groups. So when the pandemic started, we looked and tried to think about where would alcohol be interfacing with the pandemic? And we came up with basically four areas. The first two were biological effects. It's certainly possible that alcohol's untoward effects on the body could alter immune function. We know that chronic alcohol consumption increases the risk for acute respiratory distress syndrome, which is known as ARDS, basically doubles your likelihood if you're a heavy drinker, with the increased need for mechanical ventilation, prolonged intensive care unit stay, and higher incidence of mortality. And that should sound familiar because that's what happens when you're hospitalized with SARS-CoV-2. And then virus and COVID-19 infection. And then behavioral disinhibition. And this may affect the ability to take precautions for reducing the spread of coronavirus, such as maintaining appropriate physical distance and wearing a mask. And so our argument was that these two factors could be contributing to the increased risk of viral infection or the untoward effects of the viral infection. But we also hypothesized that there was another side to this, and that was that the isolation and physical distancing could lead to social isolation or loss of social support, which can lead to stress, and that stress can lead to drinking to cope. And that might be part of some changes that we see during the pandemic. And as you'll see in a minute, I mean, that's proven to be true. And then we were concerned also about treatment and recovery. Physical distancing poses challenges for those with alcohol use disorder and emphasizes the need for telehealth and virtual meeting options for individuals seeking treatment or in recovery from alcohol use disorder. And we really think that telehealth has stepped up to the plate, and I'll talk about that in a bit. But so the overall diagram shows you that, social isolation, stress can drive alcohol misuse. Alcohol misuse can drive behavioral disinhibition, impaired immune function, and that can increase the risk of viral infection and kind of closing the loop. So what do we know so far about the impact of alcohol use on the COVID-19 pandemic? Well, the biological effects. And so NIAAA research has provided some evidence that links alcohol misuse to increased COVID-19 severity and worse prognosis. These are early data. We have a number of funded grants out there that will be further looking at this, but in a study of almost 3,500 COVID-19 patients, 90 of whom were deemed likely to misuse alcohol based on clinical records, people who misused alcohol were less healthy in general and were more likely to have severe cases of COVID-19 requiring ventilation. And that's a study by Bahala et al. in 21. And another report found that among white patients with obesity and COVID-19, heavy alcohol consumption was associated with worse outcomes, basically ICU admission and death. And so these are two findings, the Valhalla and the FAN are over on the right-hand side, where you can see an emergency department with ventilator was higher in alcohol misuse. And then you can see the survival estimates in obese patients with COVID-19, and the heavy drinkers had a much more lower survival probability. What about the behavioral disinhibition piece? Well, a few studies have linked alcohol use to lower compliance with COVID-19 measures. Again, early days on the study part, but preliminary findings from NIAAA investigators indicate that in a sample of 50 young adults with hazardous drinking, adherence to public policies like stay-at-home orders is suboptimal and declines over time, and of course was associated with drinking events. And that's Sofoletto et al. In 2020. And then a study of 909 adolescents in Spain found that consumption of strong alcohol, distilled spirits, was associated with reduced compliance with COVID-19 regulations, from Rodriguez Ruiz in 22. What about the effects of social isolation and stress on alcohol misuse over the course of the pandemic? This has been the focus of much research. So we're going to review two things here: changes in stress and mental health during the pandemic, which there's a lot of data on now, and changes in alcohol use and related harms during the pandemic, which also we have substantial data at this point. So let's deviate just a little bit into stress and mental health part. So if I summarize the early research on mental health during the COVID-19 pandemic, there's been declines in mental health, both in the United States and worldwide. A research team examining the impact of COVID on global mental health examined data from 204 countries and found significant increases in anxiety disorders and major depression during the pandemic, particularly for women and younger people. And this is from the COVID-19 Mental Disorders Collaborator. And then another study reported an increase in the percentage of US adults with symptoms of anxiety or depression, and in the percentage of people who receive counseling or medication for mental health conditions after the pandemic began. A study published in 2021. And here on this slide, you can actually see from the COVID-19 Mental Health Disorders Collaborators study an increase in anxiety disorders and major depression during the pandemic in the 204 countries, and it's larger increases in women. And so the women are on the left-hand side of this figure, and the men on the right. And the pink you can see is the increases and the prevalence during the COVID-19 pandemic, and it's pretty dramatic. Even more disturbing is global increases in symptoms of depression and anxiety in children and adolescents during COVID-19 pandemic. Researchers analyzed data from 29 studies measuring symptoms of anxiety and depression in people 18 and under during the pandemic. The prevalence of clinical symptoms was 25% for depression and 20% for anxiety. The findings suggest that 1 in 4 youth globally are experiencing clinically elevated depression symptoms, and 1 in 5 are experiencing elevated anxiety symptoms during the pandemic. These estimates are double the pre-pandemic estimates, and they're higher in studies conducted later in the pandemic, suggesting, in fact, that the problem continues to worsen. And this is from a study published in JAMA Pediatrics by Racine et al. in 21. What about drinking to cope, alcohol misuse, and harms? So alcohol consumption and harms during the pandemic. The sources of data for examining changes in alcohol consumption and public health during the pandemic range, as I said earlier, from sales to survey to hospitals to national data. We'll start with sales. The sales have increased, and it doesn't look perhaps as dramatic as you might think it would, but it's been a steady but widely varying from month to month increase. And you can see that in 2021, there was about a 10% increase in sales from January to June in alcohol. And of course, this has changed dramatically because they're not premise sales, but off-premise sales in many cases during the early stages of the pandemic. But sales in general were up. What about survey studies assessing changes in alcohol use and the reason for those changes? Well, surveys of consumers in the United States and elsewhere suggested that some people are drinking more while others are drinking less. One study found that for every 1 week increase in time spent at home during the pandemic, there was about a 1.2 greater odds of binge drinking. For those who may be consuming more alcohol, limited data suggests that stress is a contributing factor. For example, alcohol use increased among college students in March, particularly among those reporting higher levels of stress and anxiety. People who said their psychological well-being was impacted negatively by the pandemic also reported more drinking days and more drinks per occasion. And higher levels of stress related to distance learning, family-oriented related issues, financial issues, and being confined to home were associated with drinking more often and more heavily. So such findings are concerning, given that drinking to cope places a person on a slippery slope to alcohol use disorder. And more recently, there was a big meta-analysis on changes in alcohol use during COVID-19 and association with individual difference variables. This was published by Acuff et al. In Psychology and Addiction Behavior just recently. And IAAA grantees conducted a meta-analysis of 128 studies from 58 countries, reporting that the overall average consumption didn't change during the pandemic, but 23% of the people increased drinking while 23% decreased drinking. And I might add that when we go through all the smaller studies that we have charted during the last 2 years, we get exactly the same breakdown. So some people are drinking more, some people are actually drinking less. But the factors most consistently associated with increases in drinking include income loss, financial stress, greater depression or anxiety, greater general psychological distress, and greater drinking to cope with stress. Other factors that they captured in the meta-analysis, demographic factors were for several measures. Women were more likely to increase drinking than males. There was a greater percentage increase, greater changes in quantity, and greater changes in frequency. Greater increases in quantity of alcohol consumption on Black and non-white participants, particularly in the United States. And then under home and work factors, there was a greater number of children in the household associated with increases in drinking. Working remotely was associated with increased drinking, and essential workers were more likely increased drinking compared to others. And again, I would argue that in the small studies that we charted throughout the pandemic, we have seen all of these points raised multiple times. And the association between COVID-related stress and alcohol use might be stronger for women. So in this study, they measured COVID-related worry and fear and current well-being in 754 subjects. More distress was associated with greater frequency of drinking in men and women, but the increases in typical number and maximum drinks per occasion were among women only. And having kids at home was associated with more drinking. And you can see on these slopes, the increases for women were much more dramatic. And we've seen this closing of the gap between men and women, and it seems to have been exaggerated, the gap closing, by these issues surrounding the pandemic. And what about alcohol consumption and harms during the pandemic? Data from regional hospitals regarding visits for alcohol-related medical emergencies, such as injuries, withdrawal, liver transplants, and I'll go through quickly a few slides here. But hospital visits for alcohol withdrawal increased during the COVID-19 pandemic. Within a New York City health system, alcohol-related emergency department visits were compared during the initial pandemic surge. That was March to May 2020 relative to a pre-pandemic reference period in 2019. And during the initial surge, hospital visits for alcohol use and use with complications decreased, while visits for alcohol withdrawal and withdrawal with complications actually increased. And you can see these data in the figure here on the right-hand side from Sharma et al. And then another analysis of data from a hospital system in Delaware also reported an increase in patients hospitalized with alcohol withdrawal in 2020 relative to 2019 and 2018. So there have been, interestingly enough, less hospital visits, but those hospital visits that people did engage in were associated with alcohol withdrawal. Because there's been a pretty dramatic increase in liver transplant referrals during the COVID-19 pandemic. This was a recent analysis supported by NIAAA that showed that referrals for patients with alcohol-associated liver disease who reported recent drinking, that it would be alcohol use within the past 6 months. These data were reported to a liver transplant unit in Baltimore, Maryland. They increased over the course of the COVID-19 pandemic. And you can see this in the slide in the orange graph. And these are ALD, which would be alcohol-associated liver disease, and RD would be recent drinking. So those that reported recent drinking were showing this dramatic increase in referral for liver transplant. And there have been rises in alcohol-associated hepatitis during the COVID-19 pandemic. In a retrospective chart review, the incidence of alcohol-related hepatitis in patients presenting to 3 community hospitals in Fresno, California before and during the pandemic, they were also increased. And what's particularly disturbing is the proportion of females and young patients admitted with alcohol-associated liver disease increased, and that's shown in the right-hand side. You can see the females in orange, and the younger than 40-year-olds in the gray there. And I might point out that, you know, we've been seeing this trend toward increased problems with liver that started pre-pandemic. They've been exaggerated by the pandemic. I met with the American Association for Liver Disease and physicians, and they were basically arguing we're in a pandemic of alcohol-associated liver disease in the United States currently. And finally, national data on alcohol consumption, hospital visits, and deaths when available. And this is some data that was recently put together from the CDC by Aaron White at NIAAA. And what you can see is that deaths in which alcohol is the primary cause or contributing cause based on death certificates increased by 26% during the first year of the pandemic. So there was a jump from 78,000 to 99,000. And an exposition of this phenomenon is in Press in JAMA, and Aaron White is the first author. And these are the listing of alcohol on death certificates. And prior, as you can see by the slope of the line, prior to the pandemic, there's been a steady increase, as I mentioned earlier, in alcohol-related deaths in the United States. But this jump is very dramatic. And it looks like from the data I've seen for 2021 that it's been sustained in 2021. This is very dramatic, in my opinion. So what about treatment and recovery? So one NIAAA supported study of adults with resolved alcohol use disorder and no heavy drinking indicated that for most participants, the pandemic had not affected their recovery. I'm sure there's going to be more data on this issue, and we'll have to see how it falls out. But in the wake of the pandemic, the role of telehealth for supporting alcohol treatment and recovery has emerged as a topic of great interest. And I'd like to just address what we think we've learned so far. So first of all, this is from McKinsey & Company, and basically shows that there was a dramatic increase in telehealth as soon as the pandemic onset. And this has been sustained. So there's still 38 times more claims in telehealth usage in February 21 than February of 20. And so we know that telehealth is being utilized. That's the point of this figure. But it also works for alcohol. So teleconferencing, brief alcohol screening, and brief intervention of college students delivered via teleconferencing leads to reductions in alcohol consumption, alcohol-related problems, and a strong therapeutic alliance comparable to in-person basics, according to a paper by King et al. What about mHealth? text messaging, mobile apps, interactive voice response technology have been found to reduce drinking and increase readiness to change, two relatively recent studies. And remote monitoring, we're still awaiting new wearable biosensors for alcohol, but researchers using the SCRAM device, the Secure Continuous Remote Alcohol Monitor, which measures alcohol in the sweat, using those devices and contingency management found reductions in binge drinking. And online support groups, 12-step programs, and other mutual support groups can help people with AUD attain and maintain abstinence, and researchers anticipate the key therapeutic elements can be replicated online. Two papers by John Kelly. And I might point out that I have met with a number of groups, particularly the Secular Alcoholic Anonymous group, and they were really over the moon, if I may say so, with Zoom, because they were able to connect with their friends and fellows all over the world, much less all over the United States. So what is the role of telehealth in alcohol use disorder treatment, and what will it be in the post-pandemic era? Well, I've already mentioned it. There was a rapid increase in expansion in the use of telehealth. Evidence suggests telehealth can be effective for addressing alcohol misuse and can reach people who might not otherwise get support. I hope that we can continue to refine and select telehealth options that really work, and they could be very, very helpful in rural communities, for example. And IAAA supports a variety of telehealth projects. We've supported screening and brief intervention with referable treatment with clinicians by phone or video chat. We've supported cognitive behavioral therapy with the clinician or self-guided, CBT for CBT. Telehealth, we've supported telehealth to address PTSD and alcohol use during sexual assault. We're supporting video conferencing-based motivational interviewing for alcohol misuse and medication adherence in patients living with HIV. And the NIAAA Treatment Navigator links an individual to effective options. I think everyone on here probably knows about the Treatment Navigator, but we launched this a number of years ago. It explains what an alcohol use disorder is, the spectrum of an alcohol use disorder, explains what the spectrum of treatments are that match the spectrum of the alcohol use disorder. And in addition, you can type in your zip code and at least find some treatment facilities through the SAMHSA locator and the Psychology Today locator that would be in your zip code area. So we anticipate a larger role for telehealth for alcohol prevention, treatment, and recovery going forward. And just to loop back to my previous point, we hope to keep the Treatment Navigator as a living document and increase the amount of information about telehealth on the Treatment Navigator as we move forward. So what have we learned from the pandemic that would help us promote wellness to reduce alcohol misuse? So factors that protect against the negative impact of social isolation during COVID-19. So if we review the literature, it suggests 3 factors can help reduce the negative psychological impact of social isolation. Family connectedness, self-esteem, pro-social behaviors such as sharing or helping others. In a study of 248 adolescents, feelings of depression and anxiety increased, and satisfaction with life decreased during the first 2 months of online learning and government restrictions during COVID-19. And we mentioned some of this earlier. But feeling socially connected during the COVID-19 lockdown protected many individuals against the declines in mental health. And studies highlight the importance of healthy social relationships. You know, social interaction is an incredibly powerful reinforcer for humans. We're primates, and finding ways to increase this social connectedness, even under situations like a pandemic, are going to be critical for ameliorating some of the negative effects of social isolation. Building resilience as a preventive strategy. So resilience refers, in our thinking, to the ability to adapt well to and bounce back quickly from significant sources of stress. In other words, to endure high allostatic loads on stress circuitry. What do I mean by that? Well, allostasis is different from homeostasis. Homeostasis, you're bringing physiological parameters, and if you want, psychological parameters back to the normal level, the homeostatic level. But in allostasis, there's a continual pressure on the system such that you're driving to a new set point. And you can think of the weight you gained during the pandemic as an allostatic change, and you realize how easily you gained that weight, and you're going to realize how hard it is to get it off. And that's an allostatic change, all right, where the set point changes, and that change in set point becomes resistant to returning to a homeostatic level. You'll see in a minute why I'm going on about allostasis. So resilience is protective against alcohol use disorder. There's plenty of data on that. By promoting healthy coping skills and general wellness, we can help people build resilience, and resistance, and reduce the chances they will adopt maladaptive strategies like alcohol misuse. Healthy relationships, positive parenting approaches, and social support from friends and or other adults helps people remain emotionally buoyant while under stress. A sense of community cohesion and links with cultural identity, including spiritual beliefs, also appears to be associated with resilience in children. We have a number of grants in our portfolio looking at this with different cultural groups across the United States. And mindfulness and exercise also help people adapt to stressors. So we wrote a paper in 2021, Trish Powell, my deputy, and Aaron White, my senior advisor. And we made the argument, and that's why I wanted to explain a little bit about what is allostasis. We made an argument that about addiction as a coping response. And I made up a word a number of years ago, and we folded this into our argument. And the argument is that during withdrawal from all major drugs of abuse, but particularly alcohol and opioids, there is a negative emotional state that evolves. And it's associated with the withdrawal negative affect stage. It's associated with certain circuits in the brain, the extended amygdala, which are illustrated here in the red. And the argument is that this negative affect is driven by loss of reward, gain of stress. You add on a pandemic and the isolation and stress associated with the pandemic, the fear of getting the virus associated with the pandemic, the economic and social upheavals that are associated with the pandemic. And we believe you're contributing, in some sense, a social component to hyperkatifia, this negative emotional states that we associate with taking excessive amounts of drugs. And we know that there are loads on the system, allostatic loads like genetics, your genetic makeup, epigenetic. There are plenty of data now showing that stress during adolescence actually can change your expression of genes that we know that are implicated in the stress response and drinking to cope. A number of basic research studies that we're doing at NIAAA, or funded by NIAAA anyway. Childhood trauma is a major, and adverse childhood events are major contributors to allostatic load and also lead to alcohol use disorder. And then psychiatric comorbidity. The comorbidity pre-pandemic was probably 20 to 30% for anxiety disorders, maybe even as high as 30 to 40% for depression, and varies tremendously for post-traumatic stress disorder, but certainly can range from 20 to 40% with that comorbidity as well. So the point here is that there is, in some sense, a biological basis for the impact of stress on excessive drinking that we've observed with the pandemic. And, I think we need to find ways in the future to anticipate and to modify our responses during these kind of situations to try and ameliorate the social isolation that might be absolute necessity with a very infectious agent, at least for some time, but also to ensure that we continue communication and support for individuals who are most vulnerable. So here's what I've talked about. I think I'm pretty much way ahead of schedule in time, so I'll be, like I said, happy to answer questions or just engage in discussion if people are interested. But anyway, the pandemic had a dramatic impact on global mental health. And this seems to be particularly true for females and younger people. Nearly a quarter of the people increased drinking during the pandemic. More increases were reported among women and some minority groups in some of the studies that we've supported. Individuals who did increase their drinking were more likely to drink to cope with stress, and I spent a lot of time emphasizing that. There is evidence for increased harms, particularly related to liver damage and death related to alcohol use during the pandemic. It appears that it may be worse for women and young adults. The use of telehealth, if there's a silver lining, the use of telehealth has increased dramatically, which may help connect more people to alcohol treatment, and may even post-pandemic turn out to be something that we can utilize in a variety of situations where treatment has been difficult to access. And there are strategies to manage stress and enhance resilience that may protect against the negative impact on alcohol misuse of living through a pandemic or any other kind of allostatic load, as I was trying to emphasize in my last slide. So I want to thank you for listening. I want to give a special thanks to my colleagues at NIAAA who helped with this presentation. Rachel Anderson and Aaron White and Bridget Williams-Simmons all helped me with the slides and pulling together the literature. And I'm, like I said, happy to discuss anything you wish or allow the organizers to give us a bathroom break if we need it.
Thank you very much for that wonderful talk. At this point, it is a perfect time for questions, and please do put your questions into the, I believe, webinar portal, or possibly directly into the chat.
There should be an option to submit a question for Q&A, but you can also type it into the chat. Oh, and it looks like we have a question now in the chat, so I can just read this out, if that's okay. So this is from Vinod Rao, and he says, I'm curious if he could expand on the use of telehealth for PTSD and alcohol. Is this data published? Were there positive outcomes?
I don't know of a chapter and verse on PTSD and alcohol with telehealth. I mean, James and John may know more than I do in that regard, so see what they say. But I'm certainly, if you send me an email, happy to query my staff and see whether there's anything out there yet. We do have a number of studies being funded currently and supplements to grants being funded currently to follow up on some of these issues. John or James, do you have any thoughts?
I'm not aware of any published data on telehealth for PTSD and alcohol. And I think that, one of the big gaps that seems to still be present is that we know that some people report benefits from telehealth, but we don't have a great sense for the difference in effect size in terms of benefit. So I think that's where there's still a lot of ambiguity in terms of how much is lost or how similar they are in reverse.
Yeah, and I think also, I think the question pointedly asked about PTSD, maybe for a reason for exposure type therapies and how that may play out over telehealth versus in person. And there may be particular moderators within the comorbid spectrum, of course, with alcohol and other drug use disorders and additional psychiatric illnesses that may mean that some things are very conducive to telehealth Other things may not be. And so this is something that we're going to need to find out.
Yeah, I would agree. And I would agree completely. And I'm hopeful that though that the pandemic will spurn us further to do exactly that, because like I said, there are a lot of people in rural communities where getting to a provider is really tricky and was tricky pre-pandemic and will continue to be tricky post-pandemic.
Yeah, I mean, I think if there's one thing that has been a silver lining out of COVID has been the recognition, hasn't it, of the accessibility provided via this platform we're on right now, being able for people to be able to get rid of an hour journey or an hour and a half journey for an appointment and the hassle of parking and all of that to be able to access this from their homes. And in rural areas as well, as George is saying, so important that we've kind of got this silver lining that we've been forced to recognize, because this was around before, but I just don't think any of us really placed the significance and importance of it the way that we've been forced to do under COVID. But I think, this is a keeper and something that will, allow people to access services for addiction and mental health through telehealth, which is going to be a boon, I think, in the aftermath of this.
Yeah, I agree. All my psychiatrist friends tell me that the other silver lining is that people keep their appointments by telehealth.
Yeah, we've seen a huge.
We have another question in the chat.
Yeah, we have a few questions, so I can go by the order they were asked. There's an anonymous attendee who asks, are you aware of any studies looking at the use of medications for alcohol use disorder during the pandemic?
Not as of yet. There are 3 approved medications for treatment of alcohol use disorder: disulfiram, which is antabuse, and camprosate, Campral, and naltrexone. But I don't know of any studies yet of any increases in use. There've been some. I just got word from David Gastrin that there's been I believe, approval of a contingency management program that they've instituted that seems to be has been taking off during the last 2 years. I don't know. Again, toss it back to John and James if they know anything. I don't know, but it's certainly something we'd like to know about.
Certainly here in Canada, there's a real challenge with an underutilization of the evidence-based medications for alcohol use disorder. And I think that given that as a backdrop to the pandemic, it strikes me as even more likely that fewer people would be getting prescription starts for naltrexone, which is often the first line agent that's most commonly used. And then there would be a higher risk perhaps of not refilling prescriptions. I don't know of data that speak to that, but I think that unfortunately, this has always been a big gap between the evidence and the actual practice of care.
Yeah, touche. That's a really big issue for us. I mean, less than 10% of people get any treatment whatsoever, and medications are even worse in the United States.
And we can move on to another question now. So Brandon Bergman asks, how has the science conducted during the pandemic impacted NIAAA funding priorities, if so? And what have we learned so far that you think will shape our research agenda in a helpful way?
So the COVID-19 per se has not really directly changed the amount of funds that have been available for R01s. It's a relatively small percentage of our budget was directly related to COVID-19. So most of our basic research programs and clinical research programs have gone on as before, but in general, there's been a slowdown, particularly in the first year of the pandemic, because most universities, the intramural program at NIAAA were all in either closed briefly or are in definite, working at half time or less. And so I think the impact has been more on young people, and they're quite concerned because they're not publishing as many papers as they normally would, and they feel like it's going to make them vulnerable to not advancing. But we're doing everything we can at NIH to support young people, and I hope everyone realizes that if you have an individual case of someone who's been impacted on their PhD thesis, on their postdoctoral fellowship, on their career development award, contact your program officer. We're very willing to do whatever we can. There are extensions given, no cost extensions on grants. All of these things are in place to help people regain their footing from the pandemic. I'm not sure I totally answered the question, but that's, the impact has been more on everyone's output and ability to do what they normally do, not so much on the finances.
And then there's another comment from Heidi Cloutier. This is a pretty long one. We are seeing a lot of youth with substance use disorders who may be reluctant to engage through telehealth or have limited ability to access telehealth in rural communities. Are there any suggestions to address this? We have several alternative peer groups operating that chose to continue to meet face-to-face, even at the height of the pandemic, because of the risk of not meeting face-to-face with youth.
Yeah, I don't have any solutions. I'll be honest with you at this point. I think given that most of the United States is now moving into, as we talked about earlier, a more, I don't know what the appropriate terminology is, living with an endemic situation. I think, maybe these face-to-face meetings with appropriate safety precautions should be reinstituted where you can. And as we have already discussed, my hope is that individuals will actually do some work on trying to find ways to adjust telehealth for some of these special situations, and be creative. But as I think it was John said, one size telehealth doesn't fit everything. So there are going to be individual things that are going to have to be developed that are going to be unique.
And then I think the next question was in the chat by Joel Chisholm. And with the proven effectiveness of online peer-to-peer and telehealth, will there be studies comparing advantages and disadvantages of online versus face-to-face, as well as with mutual aid face-to-face versus online?
I would hope so. I'm not sure whether we have a funding opportunity announcement that directly addresses that, but I would think that would be pretty high priority for NIAAA should someone want to write a grant to do exactly that.
And then we probably have time for one more question. So this is from Irina Trofimova, and about hyperketophobia, which is a concept you introduced in COVID times. Do you have more details about the changes in its rates? I presume during COVID?
No, but I'd love to have some. So anybody that's interested, go for it. The problem is going to be how you would actually measure it. And we have a program at NIAAA that was started by Laura Volkow, and is now being taken over by Vijay Ramachandra. And Vijay, we are looking at different neuropsychological tests, different scales, different measures that could be used to capture this negative emotional state panoply that I call hyperkatifia. I didn't go into much detail, but just so people understand, why on earth did I come up with a word? Well, the reason is that there's a word for physical pain during withdrawal or after trauma, and that's called hyperalgesia. And so I got tired of writing hypersensitive negative emotional state, and I wanted a word that was parallel to hyperalgesia. So I invented hyperkatifia. It's catching on a little bit. And we have a portfolio analysis of what we're doing in hyperkatifia that's in press in biological psychiatry. So you can look at that and think about where you might want to go yourselves if you're interested. You don't want to get me started on hyperkatifia. I'll go on forever and you won't get your health break.
That's right. Yeah, I was hyper caffeinated this morning, but that's different. That's different. Right?
You're not the only one.
But related. Yeah. So I think that are we going to have a look? George, thanks so much. Fantastic, and thanks everybody for the great questions and staying tuned in. James, are we going to take a little bio break now, or are we going to go straight on to your talk?
Take a short 5-minute bio break, and then we'll move on.
All right, so 5 minutes, everybody, and then we'll reconvene. George, thanks again. Absolutely fantastic. Thank you.
Thanks so much.
Hey, are we ready to reconvene? Okay. So hi, everybody. Welcome back. From that brief break. And next up this afternoon, we have our own co-facilitator here, Dr. James Mckellap, who I'm delighted to introduce. Dr. Mckellap holds the Peter Boris Chair in Addictions Research and a Tier 1 Canada Research Chair in Translational Addiction Research at McMaster University and St. Joseph's Healthcare, Hamilton, where he directs the Peter Boris Center for Addictions Research and the DeGroote Center for Medicinal Cannabis Research. He trains as a clinical psychologist at Binghamton University and Brown University and conducts a broad program of research that integrates behavioral science, cognitive neuroscience, molecular genetics, and clinical research to improve the understanding and treatment of addiction. He's published hundreds of articles and volumes and books. He's been recognized by numerous awards from national and international organizations. James, always great to work with you. I'm so glad you're contributing to the proceedings here. Take it away.
Thanks so much, John. I must say, George Koob is a very tough act to follow, but I'll do my best. And I'm happy to be participating today with everyone else and to have the opportunity to present some of the research out of the Peter Boris Center and from around Canada more broadly. In terms of my disclosures, just to make sure I'm transparent about everything, I do receive unrestricted research funding from a variety of different sources, including philanthropic sources, but also federal, US and Canadian sources. I am a principal in a technology transfer startup company and a consultant to a pharmaceutical company developing a psilocybin intervention for alcohol use disorder. I don't have any relationships with any cannabis companies, and none of the commercial activities have anything to do with what I'll be talking about today. Perhaps more importantly is I want to thank a lot of people who have contributed to the research that I'll be presenting today. The funders for the studies are CIHR, the Canadian Institutes of Health Research, and NIAAA, and in particular, the work I'll be presenting is in collaboration with John Kelly, but also Jim Murphy at the University of Memphis and Gene Costello at Homewood Research Institute. There are many, many project staff who I want to acknowledge for one of the projects, the NIAAA funded project, and for other projects for that matter also. More than anything, I want to acknowledge and say how proud I am of my trainees who have led the work I'll be presenting. Alba Gonzalez de la Roz was a postdoc at the center and is now at the University of Oviedo. Minu Minas is also an alumna who is a fellow who worked with me at the center. Sabrina Sain is currently a psychology resident who did her PhD with me in the clinical psychology program here at McMaster, and Emily Levitt and Molly Scarf are both active current clinical psychology doctoral candidates. Kyla Belisario is a biostatistician at the Peter Boris Center. And each of these people has really risen to the occasion over the course of the pandemic and basically said, if there are data that speak to what's happening, I'm ready to run with the ball and analyze data, write papers, and tell the general public what we're finding. So it's been a really inspiring process to be a part of these projects, and the credit really belongs with these trainees. So what I'm going to talk about today is kind of a big picture perspective on the COVID-19 pandemic in Canada, and how to kind of think about, in some ways, how Canada is different from the US and other countries around the world. I'm going to zero in on 4 different areas where we can understand impacts with a lot of variability. I'm going to start with opioid overdose rates, move on to effects on alcohol use, and a small amount of data on cannabis use. And then finally, I'm going to discuss some results from an NIAAA funded project that can give us some sense for how people who are actively in recovery may be affected by the pandemic. I will say that there are some caveats to my talk. This is not intended to be a comprehensive disposition on the impact of COVID-19 in Canada. I am deliberately erring on findings that speak to national perspectives, studies that have large sample sizes, and unique designs. In particular, I'm trying to highlight longitudinal designs because I think there are a lot of snapshots, but not as many movies, so to speak. Some of the work that I will report is unpublished at this point. It's typically available on preprint registries, but nonetheless, I'll make that clear as the slides go on. So this is a perspective. It's not the perspective. The other thing I'll emphasize is that I'm going to really prioritize the forest over the trees. So I'm going to show you the big picture perspectives. I'm not going to zero in too much on exact features of individual studies, but I'm happy to talk about that during the question and answer period. The last thing I'll say is that I have a somewhat unique perspective in that I'm an American who moved to Canada 8 years ago and have spent a lot of time prior to the pandemic and then particularly during the pandemic reflecting on the two countries and how in some ways they are extremely similar to each other, especially superficially, but there are some really big differences culturally also. And this has been a very interesting time over the course of the pandemic to kind of see how those differences are brought into very sharp relief. So this is a talk on the impact of the COVID-19 pandemic on substance use in Canada by an American living in Canada as a kind of asterisk. So let's start with what we know about the pandemic as it has been experienced in Canada. So to date, there have been a bit over 3 million cases. So that's about 10% of the total population. There have been a bit under 40,000 total deaths at this point. To put this in context, this is a visualization of the per capita deaths. The US has about, at this point, 290 deaths per 100,000 people. The UK has about 240. Canada has about 90 per 100,000. And Norway has about 30 and Australia 22. So you can see that there's a lot of variability, and obviously there are huge differences between countries in terms of population size. When you normalize for per capita level, Canada has had considerably lower per capita mortality relative to the US and the UK, but higher than some of the other natural comparator countries. So there has been certainly significant, but somewhat attenuated morbidity and mortality. The other thing to know about Canada is that the vaccination rate has been quite high. There have been over 80 million doses of an approved vaccine given at this point in a population of around 35 million people. A bit over 80% of the entire population have received at least 2 doses. The rates tend to be a little bit lower in young people and in rural areas, but in many of the major metropolitan areas, the rates are above 90%, and large numbers of people have received 3 doses of the vaccination also. So why is the comparative mortality so much lower in Canada relative to the US? Well, one of the reasons is that the compliance with public health measures has been quite high. And I'm going to talk on a number of slides about some data we've been collecting that has looked over time in a sample of community adults in Ontario. And these are the 7 waves of data that we've collected so far. Actually, it's been 8 now, and we'll be collecting a 9th wave in April. But this is from an observational longitudinal cohort that actually started before the pandemic and has been going on for a number of years, but accelerated during the pandemic to try to understand what some of the impacts of COVID-19 were. And to speak to this question of why there are differences in this cohort, we've been asking questions about aspects of public health compliance and vaccination rate, as well as all the other items around alcohol, tobacco, cannabis, and other substance use. And what we saw in this group of ambulatory, relatively healthy community Canadian adults over different waves is that people have been quite adherent to public health guidelines. So what you can see on the left is rates of physical distancing, reducing movement, using masks indoors and outdoors over the course of 5 waves of data collection, starting right after the pandemic lockdown started in April 2020 and going through to a year later in April 2021. What you can basically see is that people either started following the recommendations right away at very high rates, or as those recommendations changed and perhaps increased in urgency, adopted them to a large extent, and really have stuck with things like physical distancing and indoor masking ever since. On the right-hand side, you can see people's ratings of how closely they followed government recommendations, again, starting in April 2020 and going to April 2021. And this ranged from very closely following recommendations to doing the opposite of government recommendations, which is kind of an extreme version, but in any case was trying to get at to what extent are people adhering with public health guidelines. And what we see over the course of time is that people started very closely following recommendations. And even though there is a small decrease, to a very large extent, most people in our cohort are continuing to do so. So it seems that in general, Canadians are following or taking seriously public health guidelines and following them relatively closely. Now, you may be familiar with the recent protests in Ottawa. It's certainly the case that some people have been quite upset about these guidelines. And the reality is, in our own cohort, we have seen some big differences in other indicators over time. So, for example, this is an item that we use to measure whether or not people think that the government, broadly defined, not distinguishing between provincial or federal, is doing a good job. And what we found was that early in the pandemic, in April 2020 and in July 2020, on balance, people rated the government as being effective. And you can see the overall mean on the left-hand side and the actual proportion of responses to this question on the right-hand side. And you can see that nearly 85% of people rated the government's strategy as either being somewhat or very effective in both April and July. But subsequently, that has really gone substantially down and has now almost completely reversed, so that more than now only 20% of people rate the government as having had an effective response to the pandemic. So it's certainly the case that public opinion has shifted dramatically over the course of the pandemic. The reality is that even so, people continue to largely take seriously public health recommendations and follow them. And as a result, the morbidity and mortality from COVID-19 in Canada remains comparatively lower than natural comparison jurisdictions. So what do we know about impacts on opioid overdoses? This is unfortunately one of the areas that we know quite a lot about, because it is a very objective dependent variable, so to speak. Measuring, unfortunately, mortality is a very black and white outcome. And we've seen a lot of change in this area, unfortunately. To provide some background, Canada was experiencing an opioid overdose crisis even before the pandemic, for largely the same reasons that the US was, over prescription and the transition from prescription opioids to illicit heroin over time. But this has really been substantially exacerbated over the course of the pandemic. So just to give you a sense for what this looked like, here's a map of Canada, and it shows the opioid overdose deaths across jurisdictions in 2019 before the pandemic. And in that year, there were 3,600 approximately total deaths, primarily in Ontario and British Columbia. but also in Alberta to a sizable extent also. And if we then fast forward to 2020, that number goes up from around 3,600 to over 6,000 opioid overdose deaths, a 72% increase. And of course, 2020 only partially, well, 3/4 of 2020 represents the pandemic. So there has been a very substantial increase. If we look at a more granular level, these are the rates of opioid overdose death by quarter from 2016 through to the second quarter in 2021. So this now gives us a 4 observations per year and gives us a broader time window. And you can see the dashed red line indicates the original onset of the pandemic. And unfortunately, rates were not trivial in 2016. At that time, more than 600 opioid overdoses were happening annually. That's when we were already considered the overdose status to be at crisis levels. That had increased to over 1,000 per year at the beginning of 2020. There were almost 1,100 deaths in that first quarter, but that then very dramatically increased to nearly 1,700 in the second quarter when the pandemic hit, and has stayed above 1,700 ever since. It hasn't got dramatically higher, but you can see that immediately we have an almost 70% increase, and that has remained higher. So this is in part because it seems like more people are using alone, and unfortunately, if they overdose alone, there's no one to use an naloxone kit as a rescue strategy, and overdose seems to be higher. The burden by no means falls equally across the population. The majority of opioid overdose deaths are in males. Nearly 90% of them involve fentanyl. So that remains essentially the toxic contributor to these overdose deaths. And more than half of them take place in relatively young individuals between 20 and 49. Just to share one story, at the Peter Boris Center, very sadly, we lost one of our former trainees, Richard Filk, who did an honors thesis at the Peter Boris Center and worked with a former faculty member, Michael Amlung, to an opioid overdose. Rich was a very vibrant, inspiring, and intellectually curious young man. He was truly in the prime of his life. He was a yogi. He had explored yoga for substance use disorders in his empirical research. He was very active in the treatment community, and sadly, he had a lapse during COVID-19. He was using alone, and he passed away. And I think that he is just one name to remind us that all of the hundreds and thousands of people who are unfortunately dying because of this, the high rates of toxic opioids, each of those people is a son, a daughter, often a mother or father, and it's a real tragedy that we continue to witness unfolding, and one that has got substantially worse over the course of the pandemic. If we shift our focus to alcohol, it's a more complicated story. Alcohol as a psychoactive drug is pound for pound one of the most harmful in terms of its contributions to both acute harms and also chronic disease. And almost immediately with the onset of the pandemic, editorials were being written about the potential for a public health crisis around alcohol. This is one example. It's a piece that was in The Lancet in April of 2020, just about a month after, or less than a month after the official WHO declaration of pandemic status. So there's been a lot of concern about alcohol right from the start. And I think that some of the data that Dr. Koob presented suggests that there's good reason for some of that concern. In Canada, there have been a number of large-scale surveys to essentially take the temperature of what people say their experience has been with drinking during the pandemic. And These are data from 3 such scales. One study done by the Canadian Centre on Substance Use and Addiction, one done by Statistics Canada, and one done specifically focusing on community individuals in New Brunswick and Nova Scotia. All of them have relatively large sample sizes, typically between 2,000 and 4,000 people. And what we see is, in terms of self-attributions, most people say that their drinking has not changed. And interestingly, there are similar numbers of people who describe increases and decreases in drinking. And so there's variability by survey, but on balance, it looks like between 10 and 20% of people are reporting increases in drinking, and about the same amount are reporting decreases in drinking. Of course, these surveys are extremely coarse tools in terms of understanding what's actually happening. And the reality is it's much more desirable to have longitudinal data that allow us to speak to what's happening over time as the pandemic imposes different restrictions and challenges. So one of the things that we did was look at the national retail sales of alcohol to try to get a sense for what this looked like longitudinally. And these are data from Statistics Canada that we analyzed over a 32-month period, looking from basically November 2018 all the way to June of 2021, and using the 16-month pre-pandemic period to generate estimates for what we would have predicted absent a pandemic drinking to look like. And what immediately stands out is you can see that there's a clear stockpiling event in March of 2020 when the initial lockdowns were proposed. That's where we see that alcohol sales immediately went up by about 16%. They then went back down a bit, but have been consistently somewhat higher ever since. Monthly alcohol sales in Canada have historically been pretty stable at about $2 billion or just under. From the pandemic on, the sales have always been consistently above $2 billion. And you can see that that orange line is our counterfactual slope, the slope that we predicted based on the 16 months prior to the pandemic. And the actual sales have substantially or notably exceeded that over time. In terms of overall excess consumption above what we predicted, the estimate is about 5.5%, or about $1.86 billion Canadian spent on alcohol over the course of that 16-month period. So a notable increase, although not a vast increase. In addition to looking at retail sales, we've looked at changes over time in a number of ongoing observational cohort studies. So in one CIHR-funded cohort of individuals who were heavy episodic drinking emerging adults prior to the pandemic, we investigated the extent to which the early lockdown period changed their drinking by adding a supplemental assessment in spring of 2020, and then comparing people's reports to their pre-pandemic drinking behavior. And what we found in this group of young adults was actually somewhat surprising in that we saw significant decreases in percent heavy drinking days, and we saw significant decreases in adverse alcohol consequences, both statistically significant when we looked at the intra-COVID period relative to the pre-COVID period. If we looked at mental health symptoms, it was a different story. We saw significant increases in depression and anxiety, not huge effect sizes, but we saw significant increases. And it became clear that this is consistent with other reports too, especially among young adults who were typically drinking in congregate settings before the pandemic, at parties, at bars, at concerts, or at, for example, sporting events. When all of those were removed, the heavy drinking days and some of the adverse consequences also seemed to go away. We did see that there were important differences in terms of subgroups within this study also. So what we found was that when we zeroed in on those mental health changes, there were significant differences by sex. And this is consistent with some of the data reported by Dr. Koob before, we found that the increases in anxiety and depression were specific to females, not males. Males showed essentially flat patterns over time, whereas females showed much more pronounced, significant increases in depression and anxiety. We also found that income loss over the course of the pandemic was a significant moderator of changes in depression. Individuals, as one might expect, who had lost greater than 50% of their income showed much more pronounced increases in depressive symptoms. We also used this study as an opportunity to ask people the same kinds of questions that are in those big government surveys about their self-attributions about drinking. And we basically asked, have you increased your drinking, decreased your drinking, or had no change? And if people said that they increased or decreased, we asked them to estimate how much that had been, ranging from just a small change up or down of 10% to a very large change, completely decreasing their drinking or doubling their drinking. And so this gives you a sense for, out of this group of a little under 500 individuals, what the patterns of change looked like. And it really wound up being about a third in each category, somewhat similar to the national surveys that I showed you before. About a third said they decreased, about a third said they increased, and about a third, a bit more than a third, said that there was no change. What this also allowed us to do was then say, are the responses you get on this kind of a coarse self-attribution questionnaire similar to the actual longitudinal patterns that we were able to look at in terms of individuals in this longitudinal cohort study? And what we found was actually very heartening about the validity of those survey cross-sectional responses. Because if you look at these data, and what you can see here in each case is the longitudinal data categorized by people's self-attributions of their changes. And in each case, what people said they had done mapped on almost completely to their longitudinal patterns of changes. So people who said that they increased showed an increasing pattern in each case, or in this case for adverse alcohol consequences stayed the same. People who said that they didn't change looked relatively flat, although interestingly showed a decrease in adverse alcohol consequences. And people who said that they decreased did indeed show a decrease in drinking and adverse alcohol consequences. So this looks pretty promising. When we fractionated the sample even further into those finer degrees of how much people changed, we saw basically the same pattern of results. So people who said that they had large decreases showed indeed large decreases over time. People who said that they had large increases did indeed show large increases in drinking days per week, heavy drinking days, and alcohol consequences. So we do see some evidence for at least the validity of those increasingly common survey assessments of people's self-attributions. We also looked at drinking in this observational cohort that I mentioned before that has a number of additional assessment time points and has more assessments prior to the pandemic also. So here we looked at 2 waves of data collected before the pandemic, and then we looked at 5 or actually 6 waves of data collected within the pandemic. What you can see on the x-axis there also is the patterns of cases in Ontario where all the individuals were originally recruited from. And here what we saw was very interesting in terms of changes over time. So on the left-hand side, you can see percent drinking days. On the right-hand side, you can see percent heavy drinking days. And in the shaded portions, you see patterns prior to the pandemic. And to the right of that, you can see the changes during the pandemic. And what you can see is that, as you would imagine, prior to the pandemic, these were relatively stable patterns among this group of adult, non-clinical community individuals. But during the first 2 waves of the pandemic, we do see an increase in percent drinking days and percent heavy drinking days, although not dramatic increases in terms of percent heavy drinking days. What's fascinating is that actually those trends change over time, and that after those first 2 waves of data collection in April 2020 and July 2020, we see substantial decreases. And this cohort has relatively high retention rates. We maintain typically over 90% of individuals over time. So it's very unlikely that this would be to do with changes based on attrition. What seems to be the case is that over time, drinking is actually going down over the course of the pandemic. Although in that last wave of October 2021, we do start to see kind of an uptick back towards the approximate level prior to the pandemic. So what this really highlights is that although there are changes in drinking happening, they are not unitary over the course of the pandemic. And in fact, I think more broadly, we're increasingly appreciating that the pandemic is not a single event, but it's an unfolding series of events that have differing effects at different time points. In these data, we also looked at whether or not there were significant differences based on whether or not people were heavy drinkers versus light drinkers prior to the pandemic. And we classify people into the WHO's categories for risky drinking, ranging from abstinence being the lowest level up to heavy drinking being a high level of alcohol consumption each week. And when we look at the different trajectories by these different categories, green being abstinent and red being the highest risk, what we actually see is that the biggest increases were not in the individuals who were at the highest risk before the pandemic. What's most notable in terms of percent drinking days is that people who were not drinking before the pandemic did show an increase, meaning that a subgroup within that group started drinking again, not to a very large extent, occasionally, but nonetheless, that was part of the basis for that significant increase that you saw before. In general, patterns within higher risk drinkers were comparatively flat and ultimately decreased somewhat over time. For percent heavy drinking days, it was actually even more dramatic. And this is where you see the differences between the different risk groups of drinkers. And again, people are mostly flat prior to the pandemic, but after the pandemic really starts to take effect, we actually see that the highest risk group shows a sustained decrease in percent heavy drinking days over time. So the group that you would think would be actually at the highest risk actually shows favorable decreases in percent heavy drinking days over time. And just to sort of put this in context and translate it into clinical significance, this is a figure that demonstrates the average change over time for those 6 waves of data collection. And let me just walk you through it because there's a lot going on color-wise. So these are the 4 groups: abstinent individuals, low risk drinkers, medium risk drinkers, and high risk drinkers. And the first bar that you see is the individual status before the pandemic: abstinence, low risk, medium risk, and high risk. The second bar is their average status over the course of the pandemic. And what you can see is that among people who weren't drinking, a sizable group did return to drinking, but to a very large extent within low risk guidelines. For low risk drinkers, they mostly stayed low risk drinkers. A proportion did increase to a higher level, although not to high risk. And a subgroup also around 5% actually stopped drinking. For medium risk individuals, a sizable portion, the majority of people who changed, or I should say a notable portion who changed, went to low risk drinking patterns. And indeed, about 4% became non-drinkers and became abstinent. And then among high risk drinkers, a sizable portion reduced their drinking either to medium risk or low risk or abstinence levels. And that reduction to medium risk is really important because there's increasing evidence that a 1-level reduction using these WHO guidelines is a meaningful clinical reduction and may indeed be an outcome definition in future clinical trials. One last thought: these findings we see for alcohol use actually do have some parallels to mental health changes we've seen in the same cohort. So here you can see changes in depression and anxiety in the same cohort over time. Again, looking at people who, based on how high they were prior to the pandemic, and looking at changes after the pandemic took effect. And what we see there is that the most clear changes are that people who were very low prior to the pandemic show greater increases in depression and anxiety, although still stay below the clinical cutoff threshold. And people who show the highest levels above the clinical threshold prior to the pandemic actually show decreases, and in the case of anxiety, sustained decreases over the course of the pandemic, perhaps the new virtual world that we're inhabiting, making it somewhat less uncomfortable for people who are experiencing a lot of anxiety or depression. So these results really collectively suggest that it's a much more complex picture when it comes to alcohol use changes over the pandemic, with some increases and some decreases, but some of the highest risk groups not necessarily showing the changes we might expect, and a lot of the activity happening in lower risk groups. What about cannabis? What have we learned about cannabis so far? Well, in terms of cannabis, there has been somewhat less data, but there have been some similar self-attribution surveys. So on the left-hand side of your screen, you can see 3 waves of cross-sectional data collected from independent individuals by a group just up the road from us at the Center for Addiction and Mental Health. And they categorized cannabis attributions as either being increased during the pandemic or just classified them as no change or a decrease. And unlike alcohol, what we see here is that in each wave, more than half reported that their cannabis use had increased over the pandemic. And if you look to the right-hand side of your screen, this is a Statistics Canada figure showing a similar pattern to the earlier alcohol figure, in which we classify decrease, increase, and no change. And here we see about a third of individuals, not as much as the 3-wave survey, but about a third of individuals nonetheless reported an increase in their cannabis use, which was essentially 3 times the number of people who reported decreases, and a sizable increase above alcohol from the same survey that we saw before. We also looked at reasons for changes in cannabis use in these Statistics Canada data. And what seems to be the case is that this is very much driven by stress, boredom, and loneliness, although other factors are the convenience of using cannabis and ease of access. And that may be really relevant because of the changes that we see in terms of the patterns of retail sales changes. These are data from the same study that I showed you before that was focusing on alcohol, now focusing on retail sales of cannabis nationally in Canada. And one of the advantages of cannabis being legal federally in Canada is that we do have accurate estimates of national retail sales. And we likewise to alcohol looked at the 16 months prior to the pandemic and the 16 months during the pandemic to try to forecast what we would have expected consumption to look like had there been no pandemic. So this starts in November 2018, where you can see that this is right after legalization has actually taken effect. In that first month, there was about $55 million worth of cannabis sales. That steadily increased over time as legalization became normalized. Here we see the onset of the pandemic, and we see a remarkable increase in the percentage for stockpiling, about 15% stockpiling increase from February to March 2020. But then we really see cannabis sales continue to take off. And again, this orange line reflects the counterfactual slope that tells us what we expected the cannabis sales to look like had there been no pandemic. And we expected it to continue to grow based on the continued normalization of national legalization. In every case, you can see that sales substantially outpaced the counterfactual trend. They actually were about 25% higher overall relative to what we predicted, and reflected a total sales of about $800 million, more than was expected over that same time period. So this does suggest that there has been an acceleration of cannabis consumption. Of course, there are reasons to be cautious too. As I noted before, some of the self-reported increases are because of increases in convenience, and that convenience applies also to accessing cannabis. I can say personally, in the cannabis storefronts that I see, many of them advertise delivery, and during the pandemic, during lockdowns and stay-at-home orders, it may simply have been simpler, easier, and safer to order cannabis from a legal storefront rather than to buy from the contraband market. So it may be that some of these increases actually reflect the pandemic accelerating the transition from the contraband market to the legal market. Okay, what about impacts on recovery? So these last data actually come from a project that is a collaboration with John Kelly that's funded by NIAAA and includes participants from 2 sites, one in Boston, one in Hamilton. And in this observational cohort study looking at mechanisms of behavior change, we added on some supplemental assessments during spring of 2020. In the total cohort of around 500 people, which was still being actually recruited at that point, it was around 200 people. 125 agreed to give an additional quantitative assessment, and 62 agreed to participate in a qualitative assessment. In that quantitative assessment, we originally thought we would document how much of an impact the pandemic was having on relapse among this group of individuals who had all, about 6 months earlier, undertaken a significant recovery attempt. What we actually found was that there were no statistically significant differences in alcohol or other substance use from pre-pandemic to intra-pandemic using a similar design to the one I showed you before in the emerging adults. What we then tried to do is figure out, were there subgroups that might be differentially affected? And we conducted a latent profile analysis looking at whether or not people were variably affected by different outcomes by the pandemic. And what we actually saw was that the sample separated very cleanly into 2 different classes, 2 different profiles. One group actually reported almost uniformly positive impacts or silver linings of the pandemic across a variety of different areas: education, work, finances, relationships, quality of life. The other group, which accounted for about 2/3 of the sample, uniformly reported significant adverse consequences, particularly in the area of stress, anxiety, sadness, irritability, and distress, really negative affectivity. So what was interesting in this recovery sample was that there were very different impacts, in one case being relatively positive, in the other case being quite negative. And when we looked at their patterns of change in terms of drinking, these are corset plots that show each individual participant in terms of percent drinking days and percent heavy drinking days, with distributions on the outside of the individual lines. And what you can see is that the pandemic had a very complex impact on these individuals. Some people were abstinent pre-COVID and showed what essentially looked like relapse insofar as they returned to drinking on a near daily basis or a daily basis and engaging in high rates of heavy drinking also. Other people were drinking at very high rates pre-COVID, had already relapsed, and actually then went down to becoming abstinent during the pandemic. And what we fundamentally have learned from this small subsample is that it's a very complicated, very heterogeneous impact that the pandemic has had on individuals who are undertaking recovery. We also conducted the qualitative study that I mentioned before on 62 of these individuals, doing extended open-ended interviews on the impacts of the pandemic. And we then transcribed and coded all of their descriptions of the impact and classified them into these parent themes and sub-themes: impacts on recovery, recovery resources, the effects on general life. And then we were able to subclassify the consequences of the pandemic into negative and positive effects, different experiences with virtual resources, suggestions they had and barriers that they experienced, and also other ways that the pandemic had affected their day-to-day life. What I'll highlight is that we saw very different responses here too. So for example, one participant, participant 58, said, as far as the negative effect on recovery, I just drink so I can just chill and keep my anxiety down and just kind of sit around the house. I've been drinking more since the coronavirus because I just think there's nothing else to do. On the other hand, another participant told us, I think it made it easier to recover because it was like living a normal life, but with some kind of training wheels, because you go out, you can go places, but all the places with alcohol are shut down. So it was like living in a dry society for a little bit, and made building sobriety easier, I think, because it was like less temptation around it. When it came to virtual resources, we also saw major differences between people. Participant 13 said, when it came to online meetings, I tried a few times. I obviously didn't try very hard, but I just couldn't find meetings that I felt involved in, I guess. I found it very hard. I just didn't try very hard to find the meetings because I really dislike virtual meetings, especially with something awkward. On the other hand, these are 2 positive virtual experiences. I actually find the benefit of being able to be on more. I'm not waiting for a 6 p.m. Wednesday meeting, I can be online on Zoom anytime, or I actually can have more access to people because people aren't either working or they're at home or they're not as busy. I can get a meeting a day, at least one meeting on Zoom. They help a lot. It helps so much. It means you can talk to somebody and they can relate to what you're going through, and it can help you through the situation, or you can help them. You can relate to each other, and it helps a lot. So this qualitative study has really revealed to us in very rich detail how different the pandemic has been for different people, and how a one-size-fits-all approach in terms of either telemedicine or telerecovery in mutual support groups is just not going to fit well. So just to recap, the results I shared with you today are really highly variable. In Canada, we've seen very clear increases in opioid overdose deaths. That has been a major adverse impact of the pandemic on substance use disorders. When it comes to alcohol, it's a much more mixed perspective and much more nuanced. It does seem like there are increases in cannabis use, although there are reasons to be cautious about those data. And when it comes to recovery, the impacts of the pandemic appear to be very heterogeneous, and clinical research and clinical interventions are going to need to be more versatile and adaptable, it seems, when it comes to addressing the challenges brought on by the pandemic. I'm going to stop there. Thank you all for your time today, and I look forward to answering any questions people have.
James, fantastic. Thank you. That was just so nice to see that, you know, the international perspective, you know, the differences around the world, and, you know, in contrast to Canada, as well as across different substances and across different parts of the kind of clinical course or alcohol and drug involvement spectrum, from use to heavy use to disorder. So thank you for that masterful overview, just really informative and a lot to chew on in terms of those nuances. Hazel, do we have any questions?
Right now we have one question from Andrea McCone, and it is, did the abstinent individuals include those with a substance use disorder history?
I'm going to assume that that pertains to the alcohol study where we saw increases in drinking. And that's a great question. I'm not sure that we have data that speak to whether or not they were abstinent because they had an AUD history. It's certainly possible, although it is a non-clinical sample. And the increases that we see in that group are quite modest. Most of those people are showing there's a statistically significant increase, but clinically speaking, a vanishingly small number of people went from being abstinent to drinking at high risk levels. Most people went to drinking what would be considered low risk levels.
George, did you have a comment?
Yeah, that was really nice talk. And, you know, the alcohol data are not that different from what we've observed, in the sense that, you know, we had a 20% people went up, 20% went down, but I really liked your fine grain analysis. But I wonder if in your fine grain analysis, you have any metrics that could look at whether those who do increase their drinking to cope with stress.
We certainly have the data to look into that. We haven't so far. I think that you know, one of the big questions is our questions have really moved from, are there changes, to what predicts who changes in what direction. And I think that that's exactly at the heart of what you're asking about. Is it stress that's precipitating the increase? And that's one of the future directions for within this cohort, because we do have this very high resolution trajectory that we can then hopefully unpack in terms of whether or not, what are the predictors of one trajectory versus another.
Any other questions, Hazel?
We have a question from Carly McIntyre Wood, who says, Do you have any sense as to whether the increase in opioid deaths was related to reductions in accessibility to safe injection sites or healthcare in general?
That's a great question too. I think that I'm not aware of any data that speak to that. I think that one of the larger issues is that in general, there is relatively low access to safe injection sites at a population level. There are some, but they're not as widespread as is recommended. I do think that that would be one other thing that would have been restricted by virtue of COVID. But I think that what seems to be at least believed to be the biggest factor is using alone, and that unfortunately that is the biggest challenge, because social isolation may precipitate a lapse and may indeed then lead to overdose death. But it's a great question. I just don't think that we have data that speak to that.
And then there's another question from Joel Chisholm, which is regarding increased fentanyl deaths in Canada. Do we know if this is because less lethal heroin was inaccessible with the border closed, or is this increase due to COVID-related issues?
I don't think that we know that one way or the other. I do think that what we know from even prior to COVID was that there has been for a long time worryingly high levels of fentanyl in the drug supply. And that was, I believe, primarily coming from China rather than from the border being closed to the US. And I think that the composition has not changed so much as the kind of pattern of use, as I understand it. But it's an interesting question. I don't think that we have data that directly speak to it.
And then one more question from Reed Hester, which is directed at Dr. Koob, and it says, are you aware of any fine-grain analyses in US data regarding this topic?
There are some on coping, showing increases in coping, drinking to cope with stress. There are also breakdowns by sex and by ethnic groups, the RTI. I don't think there is any as complete as the longitudinal data that James was showing that I'm aware of, but that doesn't mean that some of these studies have not included it as of yet. But there are quite a few studies now where people have looked at least, cohorts over time, and the general pickup is that some people are increasing their drinking, some people are decreasing their drinking, and there seem to be a variety of reasons for those that increase and those that decrease, as James showed so elegantly. So, more to come.
And then one more question, and maybe we can take like a 1-minute break. This question is from Kyla. Were there gender differences in the qualitative interviews regarding accessing recovery tools online? With women taking on more caretaking duties during the pandemic, this could make accessing online meetings easier, or can make it more difficult with regards to distractions by young children.
Both great points. My recollection is that we did not fractionate the qualitative data by sex. It was approximately equal numbers of males and females, as I recall. What we didn't, the reason we did the qualitative study is because one of the themes during the pandemic is we don't know what we don't know. So we have to ask open-ended questions so that people can tell us their lived experience, so we can, really understand the right questions to ask. What we didn't hear in those interviews was much discussion of child care or other issues that are raised. So we didn't subdivide by sex, but I believe that had that been a significant factor, it would have emerged in the qualitative interviews regardless. Of course, I think what one can't be 100% sure, I do think that the other feature of this cohort was that the individuals who were in recovery, by and large, were typically single, as I recall. They were not a lot of people who were would be likely to be raising children, as I recall. I think that it's a mostly single group. A great question.
All right, so James, thanks so much again, and thanks everybody for the great questions. Let's take just a 2-minute break, and we'll come back in a couple of minutes, at which time we will move along with Dr. Miriam Delphin-Rittmon. So really looking forward to that talk. So come back, just a couple of minute break. We'll reconvene at 2:02. Thanks, everybody. Okay, gave you an extra minute there. We said 2:02, but you've had an extra minute, so I hope you'd enjoyed it, and we'll move right along and get back on track. Again, welcome back, everybody. I'm absolutely delighted to introduce our next speaker, Dr. Miriam Delphin-Rittmon. Dr. Delphin-Rittmon is currently the Assistant Secretary for Mental Health and Substance Use in the U.S. Department of Health and Human Services and the Administrator of the Substance Abuse and Mental Health Services Administration in the United States. She previously served as Commissioner of the Connecticut Department of Mental Health and Addiction Services and serving in that role for 6 years. Prior positions held in that office include Deputy Commissioner, Senior Policy Advisor, and Director of the Department's Office of Multicultural Health Care Equity. In her role as Commissioner, Dr. Delphin-Rittmon was committed to promoting recovery-oriented, integrated, and culturally responsive services and systems that foster dignity, respect, and meaningful community inclusion. And absolutely delighted. Thank you so much, Dr. Delphin-Rittmon, for joining us this afternoon, and I'll pass it over to you. Thank you.
Oh, thank you. Thank you so much for the invitation to be here, and definitely looking forward to our discussion. And I did send my slides along. I'm happy to share them, or I don't know if they'll be projected.
It might be easier if you can share them. Is that possible?
Let's see. It should be. This works for me most of the time.
I know the feeling.
This works here. Okay, and then
There you go.
slideshow from the beginning. No, I don't want that. Let me see.
Yeah, you want the full
other.
screen version. Yeah.
Is that the full screen? You
I
also
know. There it is.
Okay, great. Oh, so it worked.
Yeah, perfect. Yeah.
That time. That's so again, just thank you so much for the invitation to be here, and really looking forward to our discussion. It is timely in many ways to be talking about the impact of addiction on COVID-19 on addiction, as we know that March 11th, 2 years ago, is when the World Health Organization declared the public health and declared COVID a pandemic. And so much of what I'll be talking about today actually is what SAMHSA and what the Biden-Harris administration has put in place to address the overdose epidemic and the patterns and trends we're seeing within behavioral health, but I'll focus primarily on addiction. Next slide, please. Oh, I'm doing the slides. And so what I'll share is I'll talk a little bit about some of the current data that we're seeing as it relates to the COVID-19 pandemic. And then I hope to leave you with an understanding and some more information about essentially the role of SAMHSA as it relates to addressing the evolving response to the COVID-19 pandemic. And then I'll talk a bit about collective challenges that really we're experiencing as a country, and that I see us all having a role in advancing. And we'll end real quickly with some of my thoughts about the future as it relates to addiction and health services. Next slide, please. Oh goodness, that's right, I'm doing these. And so in terms of the overdose deaths and some of the patterns that we see, certainly, unfortunately, we're continuing to see tragic increases in terms of overdose deaths. And when we look historically over time, we see that, up until December 2019, the overdose rates, in fact, were beginning to level. And then once the public health emergency around COVID-19 was declared, we saw a continual and gradual increase, in fact, in terms of the overdose deaths. We know, and there's been quite a bit of discussion over the last 2 years, that certainly the ripple effects of the pandemic in terms of increased anxiety and depression. And we have data also that shows that people reported using substances more to cope with the pandemic. And so all of that likely contributed to the increases in the overdose deaths that we see. In terms of, if we drill down and look at the data a little bit further, a consistent pattern that we've seen is that fentanyl and illicit analogs of fentanyl continue to drive up the patterns as well. When we look at some of the predicted data during the 12 months ending April 2021, what we see is 49% more overdose deaths as a function of synthetic opioids other than methadone, or 48% more, greater deaths involving psychostimulants and methamphetamines. and 15% more in terms of cocaine, 14% fewer actually in terms of heroin, which is an interesting pattern. But certainly fentanyl continues to drive a lot of the patterns that we've been seeing. Looking further at the data, another additional troubling pattern that's concerning is the level of co-involvement of other substances. And so this slide here shows a range of other substances that have contributed to the overdose deaths. And essentially, what we consistently see is illicitly manufactured fentanyl is contributing quite a bit, and other opioids other than illicitly manufactured fentanyl. When we look at it overall, about three quarters of the deaths involve one or more substance. So seeing quite a bit of polysubstance use that's contributing to the overdose patterns. We also see, there's been a lot of discussion about, are substances like, or medications like methadone or buprenorphine, what is their role in terms of the deaths? Are we seeing diversion? In fact, when we look at the data, we see that fewer than 3% of the deaths involve buprenorphine, and fewer than 4% of the deaths involve methadone across jurisdictions. And again, this data is across 40 jurisdictions. The data also shows a consistent pattern of inequities as well in terms of the groups that are disproportionately impacted. This slide here shows that African Americans and American Indian Alaska Native individuals have experienced, in many ways, disproportionate impacts as it relates to stimulants and co-involvement of stimulants with opioids. And that's what each of these slides here show. Looking further at our NSDA data, so it's certainly important to look at mortality patterns and trends, and then to also drill down further and look at different substances that are driving some of those trends. And looking at our NSDA data, so this slide here is from the 2020 National Survey on Drug Use and Health, so our NSDA data, and what we see is that about 21% of Americans report using illicit substances within the past year. And you'll see the breakdown of those different substances: marijuana at 49.6 million, prescription pain reliever misuse at 9.3 million, and you'll see the trends all the way down. So we are still seeing a good deal of polysubstance use in addition to opioids and psychostimulants. And so that's something to pay attention to, and that we're watching those patterns and trends as well. In terms of this slide also is from our NSDA data, so the 2020 National Survey on Drug Use and Health. This looks at lifetime illicit drug use from individuals 12 or older, disaggregated by race. And what we see is American Indian Alaska Natives, or individuals of 2 or more races, followed by white Americans, African Americans, and you'll see the rest of the racial and ethnic groups. And for me, this slide really lets us know that it's important to sort of pay attention to culturally responsive care, social determinants of health, to get a better understanding of some of the drivers of these patterns and trends that we're seeing. And so certainly something that we're looking at and watching within SAMHSA as well. I want to shift gears a little bit and talk about, some of our priorities. In many ways, the overdose trends that we continue to see, as well as some of the behavioral health trends in terms of increased feelings of anxiety and depression, increased suicidality among some groups, increased overdose rates. All of that has contributed to our near-term priorities and cross-cutting principles. And this slide here, there's a lot on this slide. I'll go through some of the key areas, but essentially our priorities are driven in many ways by the patterns and trends that we've seen. And the goal ultimately is to, through our policies and through our funding, to be able to create integrated systems of care that create multiple entryways into services and supports. So, addressing things like preventing overdose, a key priority, given all the data that we just talked about. Also enhancing access to suicide prevention and crisis care, promoting children and youth behavioral health, integrating primary care and behavioral health, and then really looking at our data to better understand patterns and trends and outcomes as it relates to services and programs, but also patterns and trends within the population. These priorities are undergirded by our cross-cutting principles of equity. We want an equitable workforce that is recovery-oriented and person-centered, a workforce that is well-trained and equipped to address the patterns and trends that we're seeing, and also well-financed. And so these are our cross-cutting principles. And I'll talk about, in some of the slides coming up, I'll talk about some of the program areas that we're implementing, and I'll focus particularly on addressing overdose. So the department recently released this HHS overdose prevention strategy. This is a strategy that Secretary Becerra released in October. It was developed as a function of quite a bit of cross-agency collaboration across HHS. And essentially what we've developed is four pillars that comprise this overdose prevention strategy. So primary prevention, evidence-based treatment, recovery support, and harm reduction. We really see recovery supports and harm reduction as innovative work for HHS. Many departments have priorities and areas of work actually in all of these areas, but certainly the recovery work and the harm reduction work is a new area where we have specific dedicated funding geared towards addressing these areas. And I'll talk a little bit more about that in subsequent slides. I want to share now a little bit about some of what SAMHSA, as well as other, across the Biden-Harris administration, policies or practices that were put in place as a function of the pandemic. When the public health emergency was declared, one immediate goal was, certainly we want people to be able to continue to have access to services, to be able to connect to services and supports. But also we know there was a need to ensure that individuals are safe, both healthcare providers as well as individuals accessing services, so to minimize exposure. And so the next few slides that I'll go through will address some of the flexibilities and some of the policies we've put in place to both increase access, but with an eye towards the pandemic and paying attention to the transmission rates with a goal towards keeping people safe. So essentially in March 16th and 19th, there was flexibilities that were put in place around, again, increasing access to methadone. These have been so well received. We still receive feedback from individuals about how the flexibility around methadone and individuals being able to take home either 28 days worth of medications or 14 days of medications. This was actually taken up by 45 states that implemented this flexibility. And what we're hearing from people who are in recovery is that they feel more trusted. They feel like people view them as responsible, and it's given them a boost in terms of their own self-regard and their own self-esteem. So these flexibilities are definitely have been well received, and we're working towards continuing to have them in place beyond the public health emergency as well, and did administer some guidance related to that. Then in April 2020, there was a clarification in terms of the provision of buprenorphine. Essentially, that guidance allowed for buprenorphine to be administered via telehealth, including audio only, and that also has been well received. We know, in terms of access for some individuals who perhaps didn't have access to be able to do full telehealth, audio only was an additional strategy to help increase access and in some respects address equity challenges. And then also in April 2021, a new provision which allowed individuals to be started on buprenorphine without an inpatient appointment. So to be started on buprenorphine via telehealth. Other flexibilities that were put in place in May 2020 HHS and DEA designated the telehealth exception that applied to all Schedule 2 through Schedule 5 controlled medications. Again, a goal here was to ensure that people have access to needed pain medications or other medications, but are able to receive those medications or have them prescribed through telehealth measures. The DEA then in March 2020 granted an exception to this regulation to allow practitioners to prescribe medications in a state where they're not necessarily registered. So one thing that we were hearing is that there is just a need to increase the number of prescribers. And so this flexibility allowed for the prescribing of medications outside of states where individuals were licensed. And then in June, so you'll see, each of these, the goal has been to increase access to services and to needed medications for individuals through the course of the pandemic. In June 2020, both SAMHSA and CMS, we urged the use of telehealth for individuals needing substance use treatment, again, with the goal of helping individuals to connect with needed care. Then later in the pandemic, so July 2021, DEA ended the moratorium on mobile medication units by eliminating the requirement for separate mobile registration for mobile units. And so many OTPs here could then begin to stand up and implement mobile medication-assisted treatment through their existing licenses and through their existing registration. Again, with the goal of creating greater access. We understand that for many individuals in rural areas, this particular provision has been greatly appreciated. We also updated guidance and sent letters to the SSA, so the single state authorities. And we really wanted folks to know that, look, block grant funds could be used for mobile medication-assisted treatment. And so those are absolutely allowable, or is an allowable cost. And then September 2021, we released additional guidance that outlined and highlighted the fact that OTPs could now use their existing license to implement mobile MAT. And then in that letter, we also listed out what allowable services could be as part of that. An additional flexibility that was put in place, and this was in April 2021. A goal here was to increase the number of providers that are prescribing buprenorphine. So we updated and released new buprenorphine practice guidelines, removing essentially the training requirement, allowing individuals to treat up to 30 individuals with buprenorphine without the training requirement. And this slide here shows that, this went into place in April, but it was first able to be implemented in June. And so from June to February 2022, there were always there were increases in terms of new providers being able to be prescribed buprenorphine. So anywhere from 700 to over 1,000. And so this is something that we're keeping our eye on this data, but this is something that has helped to increase the number of prescribers prescribing buprenorphine. So additional flexibilities that we put in place is through the State Opioid Response Grant and other grants. We let folks know that naloxone could be purchased through those grants in different formulations. There was a period of time we were hearing that states were having a difficult time getting bulk naloxone and that the prices were increasing. So we wanted states to know that, look, any of their unallocated funds or funds that they have through Soar, as well as other grants, could be used to purchase naloxone and also fentanyl test strips. And we added that in April 2021. We also, in December, released the first harm reduction grant. And so again, this grant supports the HHS overdose prevention strategy. We released that in December. We're in the process of reviewing those grants now, so pleased with the response. And then we're also working with CDC to fund their Harm Reduction Technical Assistance Center. Ultimately, this center will help to provide technical assistance to any of the harm reduction grantees or other grantees that are implementing harm reduction. So real pleased to be able to expand our collaboration with CDC. And so these are just a few of the policies that we've put in place. There are a number of other resources that are available in terms of addressing the real critical need around some of our collective challenges. Collective challenges in terms of both stigma, but also ensuring that we have a robust, highly trained workforce that's equipped and ready to work with individuals struggling with opioid use disorder. So just a couple of resources that SAMHSA has in terms of technical assistance. We have our provider clinical support system grants. Those are grants that provide and will support training and technical assistance related to opioid use treatment and medications. And so that is a grant that addresses opioid use disorder. We also have our ATTCs, our Addiction Technology Transfer Centers. Those centers provide technical assistance and trainings, really all things related to substance use. And they can provide this technical assistance across the country to grantees as well as other individuals that request TA. And then we also have the Soar technical assistance grants and cooperative agreements. And through this mechanism, Soar grantees are able to receive training and technical assistance. And so all of these areas are geared towards helping to strengthen the workforce. And in many ways, it can help, these areas can help to address stigma as well. I think to the extent that individuals are well-trained, it can help to reduce some of the stereotypes and misinformation related to things like medication-assisted treatment, or even substance use, or individuals are struggling with substance use. So training and education can help to address stigma as well. We also have done quite a bit of work in terms of supporting the peer specialist workforce, which we know helps to close the workforce gap. And so that's an area of work that is a SAMHSA priority. We recently announced the SAMHSA Office of Recovery, and some of the work of the Office of Recovery will be to work on strategies and approaches and ensure that all of the work across SAMHSA includes the voice of individuals with lived experience and is geared towards helping to expand the peer workforce. And so all of this is critical. But we know, unfortunately, we are still seeing workforce challenges. This comes up throughout the week in various meetings in terms of the shortages that we're seeing in terms of child psychologists or psychiatrists and behavioral health professionals across the board. So this is a collective challenge, I would say that we can all work on together in terms of thinking about creative ways to expand and build out the behavioral health workforce. I've mentioned this, so stigma is definitely a collective challenge I think that we can work on together. We know, unfortunately, that stigma will often keep people from accessing care altogether. I remember a couple of years ago, as part of a community panel, and there was a parent in the audience who said that, in addition to the substances, contributing to overdose deaths, stigma also contributes to overdose deaths because it reduces the likelihood and keeps some people from accessing services, or in some community keeps NIMBY alive and well. I became aware recently of a community where there was quite a bit of concern and upkick, if you will, related to methadone services being opened within that community. So quite a bit of stigma that we still need to work on and that we can work on together. Also, in terms of the workforce, I would say training programs developing comprehensive and longitudinal curriculum on substance use and substance use disorders across medical schools and professional schools and residency programs. Exposure of students to substance use curriculum and information can increase their awareness or students' interest in working in substance use professions. And then education at the community level. And again, this is something that that we can all do together in terms of, thinking about ways to enhance community awareness of substance use disorders, with ways to reduce stigma associated with medication-assisted treatment and substance use services across the care continuum. So in terms of the, the future of, addiction-related services and supports, so, as I look forward and what I would envision is that, we have learned a lot through the pandemic. We've learned a lot. And so I think there's a lot that we can continue to implement and continue to put in place in an ongoing and universal way. Also, in terms of services, I think it's critical that our services are grounded in compassion and that they're person-centered. This is where a lot of the recovery work is so critical in terms of giving people hope and helping people to know that they're not alone, that in fact, recovery is real and recovery is possible. Also thinking about and ensuring that evidence drives practice and decision-making to achieve equitable care. And being creative in how we think about evidence. The evidences can include and should include community-defined evidence or practice-based evidence, along with evidence-based practices, such that we think about evidence on a spectrum, and all of that together can help to drive policy and equitable services and supports at the community level. Also thinking about the care continuum, a care continuum that includes harm reduction, treatment, recovery supports, and is available across different sites and different modalities. I love what I'm seeing related to some of the mobile modalities. Mobile vans or mobile RVs are even beginning to pop up. So full clinics that are able to offer harm reduction as well as treatment services. And those are brought often to high need areas using a data-driven approach. And then readily available and highly educated and robust workforce. I think this is an area of work that really ideally is ongoing. It's an ongoing area of work to ensure that the workforce is equipped to meet the evolving and changing needs that we're seeing arise. And then of course, research, that we promote ongoing research to be able to ensure that the things that we're putting in place, that they're making a difference, that they're making an impact. And I think it's critical also that we disaggregate that data to be able to look for patterns and trends based on key demographics, to be able to have an eye towards equity. So again, thank you so much for the invitation to be here. I'm looking forward to our discussion and questions, and I will stop there. So thank you.
Dr. Delphin-Rittmon, thank you so much for that fantastic overview. It was so great to see that masterful 30,000-foot view of the state of the nation, as it were, with many important data points. I love the word disaggregation at the end, because I think there's so much nuance, isn't there, in understanding exactly the subgroups who are most impacted and accounting for some of these trends that we're seeing and some of the contexts in which those effects are occurring. Thanks so much. Hazel, do we have questions for Dr. Delphin-Rittmon?
Yeah, so the first question was asked by Paul, and I think this is referring to maybe slide 6 of your presentation. And he asked, what about alcohol as a co-involved substance?
Yes, I mean, we are seeing, alcohol, alcohol use as well. And certainly that is, a substance that we're hearing and that our data suggests that communities are struggling with as well.
And then we have another question from Carly, and she asks, in regards to fentanyl overdoses, do you have any sense as to what percentage of these individuals were using fentanyl internationally versus using other substances that were laced with fentanyl? I don't have a good sense of the international data at the tip of my tongue. I know we have certainly looked at some of the patterns and trends, within CBISC. So SAMHSA has a Center for Behavioral Health Quality and Statistics. But some of what we hear certainly is that, there are challenges with fentanyl, not just in the United States, but within other countries as well. But I don't have that specific data at hand currently.
for the individual who had that question, they can certainly get in contact. So my information is on the SAMHSA website, and we can certainly send any of what we have in terms of international data and information as well.
And there are no other questions right now, but we can wait maybe a few minutes to see if people are writing questions, and we could also take a short break before our next speaker.
I have a question if no one minds. Thank you so much for your talk. It was wonderful. Number one, I just wanted to say I was so happy to hear you emphasize practice-based evidence in addition to evidence-based practice, because I really feel like that is often under discussed, and that's a high priority here. But my question has to do with, are there any initiatives for promoting more psychosocial interventions for opioid use disorder, things like contingency management or the community reinforcement approach? Because it sometimes feels like the medication-focused initiatives are taking up so much of the landscape. And that's not because I'm not a proponent also of methadone and buprenorphine, but it seems like there's a real disconnect between some of the strategies that have been shown to work and their implementation in real world practice.
Yeah, so with our Soar grant, so the state or the opioid response grant, as well as the TOR, tribal opioid response grants. So those grants often will fund a range of programs and initiatives at the community level, above and beyond some of the medication practices that we've talked about. So often those grants will focus on sort of prevention related initiatives. So working to, and all kinds of really creative approaches of, blanketing communities with naloxone, or other prevention strategies within school settings or community settings in terms of raising awareness about different substances and the dangers of substance use. But then there's also, so prevention, treatment, a range of, innovative treatments, but then also in terms of recovery services and supports. And we see quite a bit of that as well that's funded through SOAR. We have, one state that is funding employment-related services for individuals that are living in recovery housing. And that initiative includes individuals in recovery that are helping other individuals in recovery connect, who are in recovery housing, connect with employment opportunities. And so a number of initiatives that really get at some of those wraparound services and supports are typically funded through either the state opioid response grant or the block grants. So the substance abuse block grant, or the TOR, the tribal opioid response grants as well.
That's really helpful. Thank you. I know that in our inpatient addiction medicine service at our hospital, one of the big challenges is it's not hard to get a person stabilized on methadone necessarily when they're in hospital, but then if you're discharging them and they don't have, and they're in very rough shape psychosocially without adequate employment or housing or other supports, it's unfortunately not a great prognosis. So I think that's great to hear, because those are critical strategies.
Yeah, they're critical strategies. And in fact, we have grantees that are now using the SOAR grant, or in some instances the TOR grant. And recovery coaches are being connected and partnered with emergency departments, so that in some instances when individuals are started on buprenorphine and then referred for other services, they also then are connected with a recovery coach who can help them with system navigation, or even just help them with whatever they need. Often they say that they start with the question, how can I help you in your recovery today? So it's really whatever the individual needs. And so I think that partnering an individual who is connected with an emergency department with somebody else in recovery can help with that connection with other services and supports that are needed beyond the initial induction on medications.
That makes sense. Thank you.
Yeah, you're welcome.
And we have another question here. So this is from Vinod, and he says, although this is perhaps more related to DEA than SAMHSA, can you please comment about the Ryan-Haidt Act? The public health emergency seems to have facilitated telehealth access to controlled substances, including buprenorphine. How might requirements of in-person visits complicate access, and is anything possible to mitigate complications?
Yeah. So yeah, the DEA, it's definitely, DEA area. I mean, I think in terms of sort of mitigating, so what was the last part of that? Mitigating the.
So the last part was, how might requirement of in-person visits complicate access, and is anything possible to mitigate complications?
Yeah, I mean, I think certainly continuing to couple and use telehealth, I think can get at some of the challenges around individuals who may not be able to connect related to the in-person visits. So there may be some, in-person visits that are needed at some point, but leading up to that, working with a person via telehealth, whether it be audio only or, telehealth through, that includes video. It's an opportunity to have folks engage and connect to care, which may increase their likelihood of follow-up further down the line, to include for an in-person visit for some individuals.
And then there's a clarification here from Carly, who asked the first question, and she clarifies that she was wondering whether overdoses were related to intentional fentanyl use versus using substances that had been laced with fentanyl.
So overdose related to intentional fentanyl use. That's a hard one to track. It's certainly something that has come up in discussion before, that for some individuals, is the overdose and, more of a suicidal or suicide type experience for some individuals. And it can be difficult to get at that data and to track that in the absence of, information, there at the site that specifically sort of indicates such. But there is some anecdotal evidence and discussion that may be the case for some individuals. It's something we have to sort of think further about in terms of, are there ways we can get at that, or even, resources that we can connect people with earlier on. One area of work that we're working on within SAMHSA, but really across HHS as well, is the transfer of the suicide lifeline to a 3-digit crisis line and suicide line. And some of what we'll be doing is letting, through the public awareness components of this, letting people know that this is available. This crisis line is available for individuals who are struggling with substance use related crises, as well as mental health related crises, and really getting that messaging out there. So if there are individuals that are struggling with suicidal ideation and thinking of fentanyl as then it may be an opportunity to help connect and engage that individual with services and supports. So that transformation of the line, some of it is developing a line, but it is also about the 988 3-digit number, but also shoring up and strengthening the continuum of care to connect people to who are in crisis.
And I think that's all the questions we have for now. I guess we can give it 1 minute for more and then maybe take a short break.
And I just have to say again, just so appreciate the opportunity to be able to share and present. And so thank you.
Oh, absolutely delighted that you were able to join us. I know how busy you are, and it's just such an honor that you joined us. Well, I think we can sign off on from this segment, I think, of the proceedings. At this point, we're almost actually at time now of what we propose. We are due now to start the next segment at 2:45. So we could take a 2-minute break to grab a glass of water or a bio break. And once again, Dr. Delphin-Rittmon, thank you so much for giving that masterful overview. And we will see you all in a couple of minutes. Thanks, everybody.
All right, thank you. Take care.
Thank you so much.
Thank you. Bye.
Bye.
Welcome back, everybody. We are due to reconvene here in the proceedings at 2:45, and I will hand over to my colleague, Dr. Mckellap, to introduce our next speaker.
Thank you very much, John. This has been a very stimulating day so far. It's my pleasure to introduce Rita Notarandrea, who was appointed Chief Executive Officer of the Canadian Centre on Substance Use and Addiction in 2015. Ms. Notarandrea works on all levels of government, as well as the not-for-profit and private sectors, to ensure that addiction is recognized as a health issue, that it remains on the national agenda for action, and that collective efforts are galvanized to reduce alcohol and drug-related harms on the health of all Canadians. Please join me in welcoming Rita Notarandrea.
Can you all hear this?
No, I think the mute is on. I think the mute is on the player.
Oh, okay. There we go.
On the pandemic.
I'm not hearing anything. Are other people?
Still not hearing it.
Here, let me try again.
Good morning. I'm so pleased to be speaking at this timely summit on the pandemic and substance use and addiction. And I'm honored to be joining my friend and my colleague, Dr. Sam Weiss, as well as the keynote speakers from the United States, Drs. Koob and Volkow. It is wonderful as well to be at an event co-chaired by the person who has inspired and been involved in much of our work on stigma and substance use and recovery, Dr. John Kelly. And of course, a thank you to Dr. James Mckellap for inviting me to be here today. First, I wanted to acknowledge that the Canadian Centre on Substance Use and Addiction, or CCSA, is in Ottawa, the traditional territory of the Algonquin and Anishinaabe people. We are grateful to be able to live, work, and play on this unceded land. I invite each of you, from wherever you may be joining us, to take a moment to reflect on our use of this land and to acknowledge the traditional owners and caretakers of those lands. CCSA recognizes and respects the power of the traditional knowledge held by First Peoples. For those of you who are unfamiliar with CCSA, we were established 34 years ago. We are a national organization with a legislated mandate. Our organization prides itself on being an independent, nonpartisan, and trusted third-party expert on substance use and addiction. Our work is always firmly rooted in science, evidence and knowledge, and sound methodology, and it's driven by compassion. For more than 3 decades, CCSA has established itself as the voice of experience. Together with our partners and our experts in the field, we've advanced initiatives that reduce harms, improve wellness, and increase community safety across Canada. These qualities make CCSA a trusted advisor in Canada for different levels of government and across the political spectrum. The summit comes at a pivotal time. It's an important opportunity to examine how we're doing things, how we're providing quality services and enhancing access to those services, to look at our policies and education. We're getting a better picture of the story that's been unfolding, and we get to write the end of it together. Here today, we have people from all over North America and overseas. What we have in common is that we are invested in understanding the impact of the pandemic on people who use substances. By understanding and by sharing what we know, that is the evidence and overall knowledge, we can look to apply that knowledge and reduce the harm. After 2 years, we can say that the pandemic has impacted each of us in various ways, but it has been particularly challenging for people who use substances or who have experienced challenges due to substance use in the past. Our polls with the Mental Health Commission of Canada show that overall mental health issues and the consumption of alcohol and other drugs have been climbing in the 2 years since the WHO declared a worldwide pandemic. I say overall because there was a hopeful downward trend, and then that trend reversed, and Canada has set devastating new records ever since. The pandemic is highlighting the gaps in our healthcare systems. It is amplifying the inequities that continue to exclude or marginalize some groups more so than others, such as people who use substances and other populations. In those early months of the pandemic, we saw disproportionate impacts on those without stable housing. The number of people in Canada experiencing symptoms of depression rose from 2% before the pandemic to 14%. The pandemic hit Indigenous peoples and communities particularly hard, especially in the North. Even before the pandemic, rates of suicide were up to 25 times higher in the Inuit communities than in the rest of Canada. And we know that these communities are more susceptible to risks from COVID. I mentioned the polls that CCSA conducted with the Mental Health Commission of Canada. Some of the findings are alarming. They show that people with a history of substance use disorder increased their consumption of alcohol during the pandemic by 40%. Young people who use substances are using more. About 40% who use alcohol, cannabis, or both reported that their use increased. In addition, we also have an early warning system on substance use trends and issues. Our Canadian Community Epidemiology Network on Drug Use, or CENDU, which is a nationwide network of community partners that is led by CCSA, reported in the first few months of the pandemic that COVID measures had impacted the illegal drug supply. It noted early on that there are fewer drugs available, so supply and demand dictate that prices increase. It noted the supply is being adulterated with drugs like fentanyl, and that different unknown drugs are coming onto the market. CCSA also coordinates the Community Urinalysis and Self-Report Project, CUSP. This program collects data based on anonymous surveys of recent drug use from people who are accessing harm reduction services. It then compares the data with urine toxicology results. The goal is to uncover discrepancies between expected and actual substance use. The survey also includes questions about drug use patterns and needs. These can inform harm reduction services and policies at local and national levels. Once again, the results tell us that some drugs like fentanyl varied across the country, not appearing in participants in some areas at all, and yet appearing in up to 50% of participants in others. In British Columbia, deaths due to overdose more than doubled from pre-pandemic numbers. They're facing a public health emergency due to an adulterated drug supply. BC is being hit particularly hard. This province alone reported over 2,200 deaths related to opioid poisoning in 2021. That's more than 6 deaths per day in this province. Toxic drugs are now the leading cause of death among British Columbians aged 19 to 39. In Ontario, another province, the toxic drug supply related fatalities increased by up to 40% week over week compared to the weeks before the pandemic. Our Public Health Agency of Canada reported an almost 90% increase in opioid toxicity deaths from April 2020 to March of 2021 compared to the same period prior to the pandemic. Yet, one of the most difficult obstacles we have faced during the pandemic has been the limited access to and the reduced capacity in substance use treatment programs, services, and supports. This story is being repeated across our country, and it's showing no signs of stopping. As you can see from just a snippet of the data we have collected, COVID and the public health measures and social distancing has created the perfect deadly storm for people who use drugs. But this is the very reason that so many innovative health responses have taken shape these past 2 years. This is the reason we have all been working so hard, collaborating across boundaries, working together to reduce the harms being experienced. Highlighting the trends has been one of the key activities of CCSA, but the other has to do with the sharing of best practices. Highlighting what people are doing has been one of our key contributions to the field. In fact, in the early days of the pandemic, the first task for many of us was to find out more about what was going on at the service level, where the people are, what people were doing. We needed to understand more about the impacts on people who use substances and the people who were providing the services. And we needed to get that crucial information into the hands of those making the decisions and the policies. And we all needed to do it quickly. As a response, the need for quality data and evidence, we quickly set up our information hub, a one-stop shop on the impacts of COVID-19 on substance use, as well as the resources. In fact, this web resource saw more than 30,000 downloads just in those first few months. This hub features not only our own resources, but the excellent research and resources of others across our country. What we have seen is that information evolves quickly, and we all need to continue to focus on what's coming, what's around the corner. We have to understand what the needs are now, and yet anticipate what they will be. As I mentioned earlier, profiling the good work occurring across the country and collaborating with other Canadian scientists and service providers has been a key initiative of CCSA. This past year, CCSA and the Mental Health Commission sent a survey to members of our provincial territorial government to understand what their jurisdictions are focusing on. The majority said substance use and mental health are a key health system priority in their jurisdiction over the next year. Health system priority. Their top substance use and mental health priorities were responding to the overdose crisis, expanding access to substance use and mental health treatment, youth services, and increased integration of substance use and mental health services with other services. Priorities that I imagine all are familiar to many of you, and by the way, are consistent with what we've heard in previous years before the pandemic, but also increasingly challenging during the pandemic. We continue to see innovative solutions to support these priorities, and we have seen steps to mitigate harm taken by all levels of government, including the federal government. For example, class exemptions were made by the federal government to its Controlled Drugs and Substances Act so that the provinces and territories could temporarily operate urgent public health needs sites, also referred to as overdose prevention sites. There are currently 38 of these sites, which have, as of this past June, been visited more than 2.9 million times. In addition, the federal government's Good Samaritan Drug Overdose Act provides some legal protection for people who seek emergency help during an overdose. It encourages people to save a life during an overdose situation without the fear of legal repercussions. We have seen changes to provincial and territorial health acts, authorizing more professionals such as registered nurses to prescribe pharmaceutical alternatives to illicit drugs and to provide opportunities for access to treatment and supports. During the pandemic, access to naloxone increased across many jurisdictions. A coalition in one of our provinces, Alberta, reported that there were almost 23,000 naloxone kits distributed. 2,300 reported drug poisoning or overdose between April and June of 2020. And that's just one province. Our priority at CCSA is always those most vulnerable. That is people who use substance and those with a substance use disorder. But there is also another vulnerable group. With each wave of COVID-19, we all need to consider the impacts on our health workforce. There is growing concern with the psychological health and safety of health workers as the pandemic unfolds, particularly those working in mental health and substance use. CCSA conducted a survey of people in the harm reduction workforce, both before and during the pandemic. Our findings were stark, but not without hope. The people in this workforce are committed professionals, but they are increasingly vulnerable to stress, grief, burnout, and stigma. They are also at risk for secondary traumatic stress, being affected by the trauma of those around them daily, surrounded by death, and hearing the unrelenting experiences of those people who we are trying to help. I heard Dr. Catherine Smart, president of the Canadian Medical Association, present similar findings as well. She cited research that showed 2 out of 3 physicians have suffered from burnout during the pandemic. Service providers have told us that substance use workers, particularly those working at the community level and at the start of the pandemic, were not able to access PPEs because they were not deemed essential at that time. Consider that for a moment. A component of the healthcare system was deemed non-essential and not provided with the needed equipment to do their job safely. But there is hope. Our research also shows that healthcare workers continue to experience immense benefit from their work in the substance use field, that despite all of these challenges, they continue to gain meaning, joy, and a sense of community from their work. So I mention this because we need to think about this group as well. We need to ensure all members of our healthcare workforce are deemed essential going forward as we look at the lessons learned. They must be protected, must feel and be safe at work. 2 years can feel like both a very short time and a very long time. We had to pivot and quickly change how we approach healthcare and policy. And as we put things in place, to address the need, we also had to assess their impact, continuously asking ourselves, is what we're doing actually helping? Now, 2 years in, we have a better idea of what is working, and we know what is needed most, the availability of services wherever people live. People need access to a range of quality services. Those are 3 pieces to the puzzle: having access, having a choice in service based on individual needs, and having all of those services be of the highest quality. And we have seen these pieces coming together in a variety of ways. We've seen web-based supports and virtual care emerge, and they've been a literal lifeline for some, for many in fact. Fast, accessible virtual care has helped with assessments, prescriptions, and counseling. People have been able to continue with their care while maintaining physical distancing. Virtual care visits at the Center for Addiction and Mental Health, CAMH, in Toronto increased from 350 per month in March of 2020 to 3,000 per month 1 month later. CAMH also developed the HOPE app for suicide prevention. Our federal government developed the Wellness Together portal, as well as an app providing mental health and substance use care and responses to those in need at different levels. The Canadian Mental Health Association developed Bounce Back, a free skill-building program to help people manage depression and anxiety. As you can see, web-based apps developed much more so, and some specifically for those who use substances have emerged as well. British Columbia's Provincial Health Services Authority, along with the regional health authorities, launched the Lifeguard app to respond to overdose for people who are consuming drugs alone. This app is activated by a person who uses substances. It alerts 911 if the person is not responsive and able to turn off an alarm after 75 seconds. We have addressed access to a certain extent, but we are also aware of some barriers, of course, when it comes to virtual and online supports. New research is showing that many people using virtual supports and services for substance use are now comfortable with meeting a healthcare provider virtually. Overall, people understand the restrictions, but are generally satisfied with the virtual care and services they are getting. However, in our research, less than half said that virtual visits were just as good as in-person visits for building a relationship. And many cited barriers such as a lack of computer equipment, internet access, or a quiet, private, or safe space to access them from. All of this tells us we will need to provide a flexible and tailored approach to providing both virtual and in-person services and supports. This approach must be based on the evidence, and it must consider both the clients and the practitioners' experiences. We have seen so many other innovations. In Ontario, as one example, a few organizations, including CCSA, completed a study on the results of unsupervised opioid treatment during the pandemic. And in short, the results indicated that the change to unsupervised did not lead to any additional adverse events. In fact, it improved relationships between healthcare professionals and their patients. The list of innovative solutions put in place across the country goes on. The key had to do with developing these solutions in such a short period of time and evaluating them as we went along. So as we evaluate the impact of these innovations, I'm hopeful that we will scale these programs provincially, nationally, and of course, as we continue to share their successes and lessons learned, that we will see them scale up internationally as well by our international partners. So during this time of rapid learning, all of the pieces of our policy and health systems are being evaluated. Decriminalization and diversion are other approaches to limiting the harms of substance use that have been increasingly discussed during the pandemic. There are currently 3 bills being debated in the House of Commons in Canada that propose alternatives to criminal sanctions for the personal possession of illegal substances. From a Canadian perspective, decriminalization means the removal of criminal sanctions for possession of small amounts of illegal substances. And while it is not a solution on its own, evidence shows us that decriminalization promotes a health and social approach to substance use. It limits the harms associated with substance use policies, such as criminal records, stigma, and barriers to future employment. Also, in response to the devastating impact of a toxic drug supply, there has been action towards securing a safer drug supply. However, many barriers have been cited to making safer alternatives available, including supply, political will, and the availability of an accessible continuum of care and treatment. Safe supply programs already exist in Canada, but not on a national scale. We have seen interest in expanding access and availability of these programs. The federal government is currently providing funding to 18 safe supply projects in British Columbia, Quebec, Ontario, and New Brunswick. And it has committed an additional $116 million in their 2021 budget for their substance use and addiction funding program. This allocation of funds includes safe supply funding. So just as the pandemic has highlighted the cracks in our healthcare system, which have been made wider for many, we have the opportunity now to not just patch them, but to really, really fix them. The momentum is there. Substance use and addiction need unique attention, focus, and investment. This was recently illustrated in Canada when our federal government created the role of Minister of Mental Health and Addiction, separate from our federal Minister of Health. A separate health ministry to recognize the importance of mental health and substance use health and the needed focus. In fact, 6 jurisdictions across the country have done the same. We have the opportunity now to take a coordinated approach, but also a much needed all-government approach to substance use health, recognizing that there are many paths to substance use disorders and many paths to overall wellness. So in addition to creating an accessible, evidence-informed system of care for people who use drugs, we need to look at safe housing, meaningful employment, and an end to the stigma that is a barrier to wellness for so many people who use substances. We need to build and invest in sustainable capacity. We need healthy and sufficient numbers of practitioners, sufficiently compensated irrespective of where they work in the system, i.e. hospital or community, and with the necessary training, competencies, and resources in this field. And equally important, they need to be situated within the broader healthcare system, to be part of the system rather than external to it, as so many programs currently are. This is where we need to be headed. But all of these changes are for naught if people who need services do not feel safe seeking help. As we have learned from Dr. Kelly's groundbreaking work, the stigma around substance use is one of the biggest hurdles to wellness and good health outcomes. Stigma has devastating real-life consequences. Substance use disorder is a complex health condition. It cannot be resolved by any level of government or any one organization. We know that it is not a moral failing or a choice. We also need to appreciate that not all substance use is harmful. One of the ways that CCSA is addressing stigma is to change the language we use to describe substance use and those who have a substance use disorder. In addition to a number of modules and workshops, we've developed a guide for journalists. The guide focuses on using non-stigmatizing language in their stories to put people first in the language and the descriptions they chose, and the benefits of doing so. While we're just beginning to roll out the guide, we've received promising responses from those in the media that we have approached. The latest edition of the iconic Canadian Press style book now instructs journalists that they have an important role to play in reducing the stigma and the negative images and characterizations that have long surrounded alcohol and other drug use. Changing language can change experiences and lives. So as we continue forward, we can't ignore the lessons that are here for us to learn from. Innovation can be done quickly with positive outcomes if we are flexible enough to let it happen. We need to continue to measure, evaluate, and change policy and practice as we have done to keep serving people who use substances in the best way possible based on what we know and what we are learning. Sharing and using the latest evidence that continues to evolve is a must, and we must apply this evidence and the lessons learned. Healthcare workers in our field need our attention, and in particular, those working in the substance use field and at the community level. What do they need, and what does our system need when it comes to these health professionals and the overall skills and competencies? Availability of and accessibility to quality, diverse substance use services needs to be similar to what we expect for other specialized services in our Canadian healthcare system. And significantly, people who use drugs need to be supported not only by the substance use and the mental health sectors, but by the system at large, as anyone else seeking care would be, respectfully and without stigma and discrimination. There is no one answer to solving the impacts the pandemic has had on our health system, our workers, and on people who use substances. The solutions are as varied as the people who seek them, so our solutions need to be guided by them. And it is critical that they have a choice in the service they need and want to address harms. What we have learned above all is that we all have a key role to play. We can work together. We can work quickly and innovate quickly. We can remove those barriers that had existed for years when there is a collective will and effort. We can bring about the needed changes. As we move into our third year of the pandemic, and as I approach my retirement, in fact, my hope for the field, for all of my colleagues, for all those tirelessly working on solutions at different levels, is that we continue to act on what we know works. We continue to evolve as needed, continue to address the barriers given the momentum that there is now, and that we treat people with the respect they deserve. And overall, that we continue to move forward together and building on each other's strengths and the lessons learned. Thank you.
Excellent talk. Now, because that was pre-recorded, we won't be having any questions from the audience at this point. Why don't we take a break for 10 minutes since we have Dr. Volkow on the schedule for 3:30. Thanks, everyone. Okay, welcome back, everybody. Our last, but by far not least speaker of the day is Dr. Nora Volkow. Dr. Volkow became director of the National Institute on Drug Abuse, NIDA, in 2003. Her work has been instrumental in demonstrating that drug addiction is a disease of the brain. As a research psychiatrist and scientist, Dr. Volkow pioneered the use of brain imaging to investigate the effects and addictive properties of misusable drugs. Her studies have documented changes in the dopamine system, affecting, among others, the function of the frontal brain regions involved in motivation, drive, and pleasure in addiction. She has also made important contributions to the neurobiology of obesity, ADHD, and aging. Dr. Volkow has published more than 580 peer-reviewed articles and has edited 3 books on neuroimaging for mental health and addictive disorders. Please join me in welcoming Dr. Volkow to our conference.
And it's a privilege for me to be able to speak with you about some of the challenges that we are facing in substance use disorders, and particularly on the overdose crisis and how this has been exacerbated by the COVID pandemic. I will hope that the next meeting would be in person and we have an opportunity to actually interact and learn from each other. The COVID-19 has had a devastating impact in the use of drugs in our country. And this, of course, has been most notable as it relates to the very significant increases in overdose deaths that we have seen during the COVID pandemic. But the negative effects go actually way over even those of the overdoses, and they relate even directly in terms of how are people suffering from substance use disorder, how themselves are being affected by the COVID pandemic. And this is important because drugs affect many of the physiological systems that are actually targets of the COVID infection. Most notable, the lungs, the cardiac system, and the immune systems. All of them are affected in different ways by both legal and illegal drugs. So in that respect, on the one hand, that one would be of concern that this group would be at higher risk of severe COVID outcomes. Also, the disadvantaged situation that people with substance use disorders encounters themselves is likely to put them in situations of greater risk of infection. And indeed, the data has shown effectively that individuals with different types of substance use disorder, whether it's alcohol, cocaine, cannabis, opioid use disorder, tobacco, all of them have significant increased risk of infection for COVID-19. And this is based on analysis of electronic health records. And this analysis also reveal not only are they much higher risk of infections from COVID-19, but they also, if they get infected, they were much more likely to die from those infections. And this data to the right shows the mortality rate on individuals that don't have a substance use disorder, separated by race ethnicity between Black and white Americans, showing that more Black Americans were dying of COVID, and this was recognized from the beginning of the epidemic. But when you compare these numbers with those of individuals with substance use disorder that got COVID infection, the mortality is even much higher. And this mortality is further accentuated among African Americans, indicating that individuals with substance use disorder, as one would have predicted from the very adverse effects of drugs in health, will be at higher risk of adverse outcomes, but also highlighting how despite the very significant increases in risk, you still are able to see the health disparities in outcomes between Black and white Americans with substance use disorders. A more detailed analysis of the data for the electronic health records identified indeed that the rates of many medical conditions, chronic medical conditions that have been shown to increase the risk of COVID are significantly higher for individuals with substance use disorders. So here we have in red individuals with substance use disorder versus blue individuals that don't have such disorders. And whether it is for diseases such as COPD or diabetes or hypertension or obesity or cancer, the rates are significantly higher among individuals with substance use disorder. And the high prevalence of these chronic medical conditions has basically been neglected across the whole substance use field. And in particular, it reflects the fact that physicians are not necessarily screening for a substance use disorder in their patients. And there also, too, the disadvantage of individuals with substance use disorder vis-a-vis access to care. So they are less likely to receive quality care and therefore more likely to develop more severe and chronic medical conditions. In this backdrop, it's not surprising that also when subsequent analyses were done in the electronic health records to assess differences in breakthrough infections between those who were vaccinated and non-vaccinated, and this data is before the Omicron variant period, it predominantly reflects the Delta period. And you can see that indeed the individuals with a substance use disorder, whether it is in this case, I'm highlighting the two conditions, the substance use disorder, which had the highest rate of breakthrough infections, tobacco use disorder, as well as cannabis use disorders, indicating that those negative effects from use of drugs are also making them more vulnerable to breakthrough infections, presumably too as a function of the deleterious effects of these drugs in the immune system. Now, well, what about the overdose crisis, which obviously before the COVID pandemic, we have not been able to resolve in our country and was still growing. This was of major concern too, because we knew at that time that there are systems that are actually promoting the overdoses in people that have a substance use disorder, including the stigma and the structural system that actually treats individuals with substance use disorders on their very sometimes non-optimal conditions, and including in many instances much higher rates of incarceration. These conditions that lead to congregation of individuals, of course, are likely to result obviously in higher rates of infection. But it also, the stigmatization, the closing of support systems in the community, and including the access to emergency department for healthcare support, all of those were closed down or curtailed during the COVID pandemic. So when one looks at what is it that we are observing in light also of the tremendous uncertainty and stress that COVID pandemic has placed in all of us, therefore, it is not surprising that across the United States, certainly we are seeing an increase in the use of substances, and we're also seeing an increase in the relapse of individuals that we're aiming for recovery of substance use disorders. And this shows data at the beginning of the pandemic that basically of the positivity in treatment programs for substance use disorder for different drugs, cocaine, fentanyl, heroin, and methamphetamine, in comparing the 3 months before the declaration of COVID national emergency and those that follow versus the equivalent of the year before. And you can see the significant rise in the number of individuals that had urines positive for, in this case, fentanyl is the largest increase, but we're also seeing increases in heroin, which is the lowest, and methamphetamine, as well as cocaine. The data to the right is a different laboratory that's also measuring the urine content of individuals that are referred to by justice, the justice settings or by treatment programs, and showing that indeed the differences between before COVID and after COVID for individuals of different ages, there were significantly higher percentages of urines that had fentanyl positivity. And when you take this, the drug with higher presence, where you see the highest rise with the COVID pandemic is fentanyl, and you see it here across all ages, basically gives us a cause for concern, because this is an extremely potent drug that is associated with very high risk of overdose and mortality. The other issue of major concern, if one looks at the drug seizures that have occurred since 2014 to 2020 representing the COVID pandemic, one can see that there is a very significant increase in drug seizures, which actually are going to be reflecting the drugs that are going to be available in the community. In cocaine, it's interesting because the increase is observed from 29, what had been observed already before the COVID pandemic. So before and after in these 2 years is not so dramatic as, for example, what one observes with methamphetamine, a very, very dramatic rise. Heroin actually has been quite stable, and if anything, there is actually appears to be a reduction as more and more the illicit market of opioids goes to fentanyl. And you can see the progressive increase in the seizures from fentanyl. And while this is progressive, you can see that the jump between 2019 and 2020 is greater. And unfortunately, this may have expanded even further in 2021 and 2022, as it becomes clear that the fentanyl distribution is much more profitable than that of heroin. When you have those already that data, and then you look at, well, what does this mean in terms of overdose mortality? And CDC, of course, has been monitoring overdose deaths, and it usually comes with a delay of 6 or 7 months. So this is data up to June 2021, where there was noted for the first time that the number of overdoses in 1 year was over 100,000. And this horrible milestone was achieved due to the very high rates of overdose mortality that we have seen during the COVID pandemic. And if you look at where the increases are, what are the drugs that are ascribed to have contributed to overdose death, you can see the notable rise in 1 year from fentanyl, and the notable rise in 1 year predominantly from methamphetamine. So it is clear fentanyl is more and more are detected in the presence of overdose mortalities. In some areas, and treatment programs, they no longer detect heroin, they detect fentanyl. In some areas in the Northeast, for example, basically most 75% or more of the mortality is driven by fentanyl. But also there is a significant rise on deaths coded with methamphetamine as a contributor. 75% of the deaths that are associated with methamphetamine also have fentanyl, which highlights the reality of the illicit market right now, that drugs are basically being mixed on purpose or unbeknownst to the users. So in this situation, from the perspective of the science, what is it that NIDA is doing in terms of funding research? What are the opportunities? Certainly, we've come to realize that the most impactful interventions that we have to prevent overdoses are, number one, distribution of naloxone, and made it as widely available and accessible as possible. And the other one is expansion of the use of medications for opioid use disorder, whether it is methadone, buprenorphine, or naltrexone. The three medications are the most effective way of preventing someone from overdosing. But a challenge has been ultimately to keep people in treatment. And that opens up the question on the door, are there alternative treatments or support systems that can be given to enhance retention in treatment and to provide, again, other interventions that may be useful for patients that don't necessarily respond to the medications for opioid use disorder. Similarly, in the case of overdoses, while naloxone is almost like a magical drug in its ability to reverse overdoses, it is clear that in some instances, particularly when overdoses are associated with fentanyl, naloxone may not necessarily be sufficient to reverse those overdoses. So there is need for better alternative ways to support people, both in terms of overdoses and in terms of treatment. In the world of the reversal of overdoses, one of the big challenges with fentanyl is that these drugs get into the brain very, very rapidly. And as a result of that, individuals can overdose abruptly and die even before anyone can come to save them. And so the development of automatic devices that can actually detect when someone is overdosing and activate a support system or an emergency system that can deliver naloxone, or actually closed loop delivery systems that can deliver naloxone when those thresholds are met and to prevent an overdose are one of the areas that we're working with. In parallel, researchers are working with use of monoclonal antibodies, whether it is methamphetamine or monoclonal antibodies against fentanyl, to provide with alternative interventions to reverse toxicity. drugs that can sequester drugs, methamphetamine or fentanyl, is another possible intervention. And in the space of treatments, there is research ongoing to develop formulations that will make it easier for patients to receive their treatment. For example, extended release formulations of methadone will make it so much easier for an individual who's been maintained on methadone to be compliant with their treatment. It will make it also much harder to actually divert and misuse for other purposes. Similarly, the development of extended release formulations of buprenorphine has made it easier to deliver in justice settings where there is the need to have more control over the distribution of these medications. In the meantime, science has evolved and we have a much better understanding about what are drugs doing to our brains, which are the circuits that are affected, and how the dysfunction in those circuits then drives the behaviors that we see in drug addiction. And with developments in neuromodulation technologies that can stimulate or inhibit certain areas in the brain, it is now possible to intervene with them to actually help improve outcomes in individuals with substance use disorder by either strengthening, for example, the prefrontal cortical circuit that is important for self-regulation, or inhibiting areas like the insula, which is actually engaged in recognition of craving and desire for drugs. So through this, and there are multiple ways of stimulating or inhibiting, we're also being very, very proactive, not just in working with pharmaceutical industry, but also working with big pharma and small pharma, and with investigators to actually help them develop products that go from the basic discovery up into the clinic. But all of that research, which actually is very important because it can lead to in the future better treatment, in a way has to go in parallel to the recognition that right now we also need to do research that can improve the outcomes of people suffering now from a substance use disorder. And that's where implementations of service-based research becomes very, very clear. It is evident, we know, and I mentioned that the two interventions that we currently have that can produce the largest impact in overdoses are interventions that expand access and retention in medications for opioid use disorder, and expand access and availability all throughout for naloxone delivery. And that actually would benefit from involvement, not just on specialized treatment programs, which actually have restricted ability to take care for the large number of people that need help, but also take advantage of healthcare organizations, of justice settings, and of the communities. So we are targeting implementation research that will advance the ability of the healthcare system to engage in the screening and initiation of treatment and follow-up of treatment of individuals with substance use disorder, including opioid use disorders, including adults and adolescents. In the justice setting, that's another opportunity because individuals that have a substance use disorder and opioid use disorder too, specifically, are much more likely to be incarcerated. And if they are incarcerated, they are at much greater risk of dying when they are released into the community because they are no longer tolerant. And yet the work has shown now, at least for 15 years old, that interventions that initiate medications while in jail significantly improve the outcomes, preventing these patients from overdosing. And recent data actually show that they also significantly reduce the likelihood of reincarceration into jail systems in rural areas. And finally, the HEAL initiative actually has taken a bold approach by delivering the project that we call Healing Community Studies that integrates the evidence-based interventions that have been shown to be beneficial and brings together healthcare, justice, and community to implement them. It is carried out in 67 communities in the United States that have some of the highest rates of overdose mortality. And in 4 states, New York, Kentucky, Ohio, and Massachusetts. So that's in terms of the overdose crisis. But that's not the only aspect of the field that has been affected during the COVID pandemic. One of the questions and a priority throughout in research in NIDA has been to understand the pattern of drug use among teenagers, because teenagers, that's the stage in life where most people experiment with drugs, at a higher risk also, to start experimenting with drugs, and use of drugs at that stage in life is likely to be associated with worse negative outcomes, including higher risk of addiction. Interestingly, during the COVID pandemic, this is data up to December 2021, we've observed a significant decrease in drug use among teenagers. And that you see for 8, 10, or 12 graders. And this is data of any past year illicit drug use. So drug use among teenagers in the United States went significantly down. And again, this includes also for alcohol, tobacco. We are seeing some of the lowest rates ever seen. And we're also seeing we are seeing the largest rate of decline ever in one single year. And this is likely to reflect, and I think that it forces us to think about what has happened is probably related to the fact that we know that teenagers are basically, in teenagers, drug use is a peer group behavior, and to the extent that there was social isolation and less opportunity to be together, that reduced the chances of these teenagers to consume drugs. And here you have the data for 2020 versus 2021, and for 8, 10, 12, and 12 graders for alcohol, marijuana, and vaping nicotine. So each one at the left is the 2020, and the right is the 2021. For 8, 2020, 2021, for 10, 2020, and 2021 for 12 graders. And you can see on every single one, a decline in the use in one single year. Look at this, and as I say, some of these declines are the largest we've ever seen. You can see it also in marijuana, you can see it also for vaping nicotine. And in this year, the largest changes that you can basically observe just from this graph were in the 10th graders. But that's not the only thing that has happened. I mean, and that in general, the reduction in drug use among teenagers is a very good trend, it's a positive trend. I mean, obviously in prevention efforts, we're aiming to do that. But unfortunately, in this case, the isolation also comes at other cost of mental health that we know could negatively affect in the future the trajectories of drug taking. So for example, currently, we do not know what will happen in terms of patterns of drug taking once these teenagers get back to school and resume their activities to the levels that they were before the pandemic. Also, very importantly, we know that the pandemic has dramatically changed the way that teenagers learn and interact with one another. And yet we know that those interactions with other teenagers and other members, other adults are very, very important in the development of the human brain. And the human brain continues to develop until our mid-20s. And one of the most important factors that's driving that development is the complexity of social interactions. So what happens in brain development when you go from here to here? What happens when you actually, and people have said in terms of the missed opportunities to interact and play with others, how that affects the well-being of teenagers. Through the ABCD study, which we started in 2016, we're following close to 12,000 children longitudinally until 2026. And we're monitoring their brains with MRIs, with multiple tools for MRI, as well as cognitive development, social skills, behavior, physical activity, sleep patterns. And this is done periodically. And we also supplemented researchers from the ABCD study to be able to document how these teenagers and their parents were affected by the COVID pandemic. And this is data from those surveys that were supplemented. And it shows the effects of, this is different from the data that I just showed you, that in monitoring the future, where you see the significant reduction in drug taking among 8, 10, and 12 graders. This is data from ABCD that is actually reaching out to younger children, 11 to 12 years of age, and determining their any substance use before and after the pandemic. And it's interesting because as teenagers grow older, of course, there is an increase of drug use. We just see here that overall, that 12 years old have greater use of substances than the 11 years old. But the pattern of changes in drug use with the pandemic differs and is lower in alcohol, for example, where it seems to be appearing higher in nicotine. And there is also higher in prescription drugs. And this is likely, again, to reflect the conditions by which these drugs are consumed are different. For example, in terms of alcohol is a behavior that is done socially. Again, access to cannabis in this age group is very difficult without access to other teenagers. Access to prescription drugs may be facilitated since those are basically obtained from the cabinets that parents may have from their own prescriptions. And two, in looking at these patterns of drug use, a very important question is what's driving these changes? Why is it that in some teenagers, the pandemic has resulted in greater use and in other in lower use? Investigators are trying to understand what factors contribute to exacerbating drug use. And these are factors to the right that increase the risk of a teenager consuming drugs. And there are no surprises. Overall, we know that if these are the most notable, the ones with the largest effect, we know that if the parents themselves are taking drugs, whether it's cannabis or nicotine, then those children are more likely to take drugs during the pandemic. And similarly, the perception of stress and the levels of anxiety and depressive symptoms in these young people also are factors that are contributing to them using drugs, presumably as a way to auto-medicate that distress. Again, highlighting what we've recognized as factors that are very, very relevant for pinpointing about the need to do prevention efforts to address this. Similarly, in terms of mood, the surveys from the ABCD have shown that in some cases, the negative mood and the stress and the depression has actually worsened for some teenagers, whereas others, this has not been the case. And indeed, they may have actually shown a reduction or no change in worry or depression. And the extent to which the COVID pandemic has exacerbated basically sadness, fear, and worry, and reduced positive affect, that basically is identified by children who have been exposed during their life to greater numbers of adverse childhood events, which again, we know are contributor to negative mental health states, as well as substance use disorder. And as we are all conscious that as we start to emerge for the COVID pandemic, some of the most affected are teenagers in terms of them struggling with depression and anxiety. And while as of now, we're seeing a reduction in drug use among these teenagers, and we're also seeing a reduction in suicidality, once we emerge, these teenagers may remain with a heightened risk of actually a negative outcome. So we need to be vigilant. The other extraordinary important component of the COVID pandemic actually is not just its negative effects on teenagers, but also on infants. And so as a result of that, and the same thing in terms of we've known this, the negative impact that the environment, the adverse childhood events basically start in infancy and follow up. And so we initiated last September a large study, just like the ABCD, in partnership with several other institutes, to actually monitor longitudinally the outcome in close to 7,500 infants from these areas in the United States, to determine how ultimately exposure to adverse environments, exposure to opioids during pregnancy of the mother, ultimately affect brain development and future outcomes. And because the study had already run pilot projects 2 years before the initiation in September of last year, we were able also to add information that relates to how did COVID infection during pregnancy ultimately affect the brain development of these children, these infants. And this is relevant because many women have been exposed to COVID during pregnancy, and we need to understand how that by itself or in combination with drugs, including opioids, can affect the outcomes. Also, some of these infants are going, just like with the ABCD, some of these adolescents are going to be infected themselves with COVID, and we need to understand how that affects their brain development. And both from the perspective of viral infection, but also importantly from the perspective of the immune responses that then can affect brain development. This is an example of one of the studies on in the pilot program just before the HPCD was launched, which actually evaluates the myelination of the brain of 38 individuals, infants whose mothers have been infected with COVID versus those that actually had no COVID infection. And what this data shows in this one, exposed versus not exposed, is a very significant reduction in myelination of the infants born out of mothers who were infected. And this is another study that actually addresses the issue that is not just the infection itself that may affect the myelination, but ultimately the mental state of women when they are pregnant can influence, and it's known to influence behavioral outcomes in their infants. In this case, the data shows that the scores of anxiety and depression this is data on 8,602 women, were higher during the COVID pandemic. And some women have higher scores of distress than others, and that is mediated, important message, by the social support systems that you have, which of course is intuitive. The stronger your support systems, the less likely that you are going to be responding with negative emotions. But in these newborns, the development of important tracks, white matter tracks that connect areas of the brain, for example, the uncinate fasciculus, which connects limbic areas with prefrontal areas, and this is prefrontal with amygdala, is directly associated with the level of distress of the mothers, indicating the importance of COVID in terms of brain development. And in this case, all of these are infants born of mothers that were not being exposed to drugs, where we can basically predict that the distress in women who have a substance use disorder problem is likely to be much worse. And by itself, the drugs themselves, which affect immune function, may lead to worse outcomes. And I want to end the presentation with this slide here, because it actually highlights that as we navigate the world, and I showed you ultimately how the adverse consequences from the COVID pandemic actually were much worse in individuals with substance use disorders. And then among the individuals with substance use disorder, there were much worse among African Americans. And among those that are overdosing, we're seeing that the highest rates of mortality are among Alaskan Natives and American Indians and in Black Americans. And here we have, I end up with disparities in excess mortality with COVID-19 in the United States. And this is for difference of people of different ages. It doesn't matter, less than 25, 25 to 64, more than 65. And here you have the different groups. And what jumps at you, and these are different factors from the COVID of 2020, sort of the death rates have gone down because we've learned how to treat it better. But despite that, look at the excess mortality that we see in terms of Black Americans, and look at the excess mortality that we're seeing in American Indians and Alaska Natives. And again, the devastation that COVID has created, the devastation of the overdose crisis, is ultimately permeating and exacerbating in these groups. And as we look forward, I mean, you've been noting that I very explicitly stated what is it that we need to do. And it is clear that we need to enhance supportive systems, and because it is those supportive systems that will act as resilient factors that will allow us prevention from drug use. And it is those resilient factors and the social support systems that will allow people that are in substance use disorder to actually be able to recover and to ultimately, for all of us, to benefit in the process. So with that, I want to thank you for your attention, and I wish you an enjoyable rest of the meeting.
Very stimulating talk indeed. So to conclude the formal part of the summit today, we're now going to have John provide a synthesis and serve as a kind of meta discussant for the various talks that we've heard today, and help kind of wrap our heads around all the different data points that have been presented. So just to give a due introduction, Dr. Kelly is the Elizabeth R. Spaulding Professor of Psychiatry and Addiction Medicine at Harvard Medical School, the first endowed professor in addiction medicine at Harvard. He's also the founder and director of the Recovery Research Institute at the Massachusetts General Hospital, the associate director of the Center for Addiction Medicine at MGH, the program director of the Addiction Recovery Management Service, and he served as a consultant to U.S. federal agencies and non-federal institutions, as well as foreign governments and the United Nations on the topic of substance misuse and addiction. Dr. Kelly has published over 200 peer-reviewed articles, reviews, chapters, and books in the field of addiction medicine, and was an author on the U.S. Surgeon General's report on alcohol, drugs, and health. His clinical and research work focuses on addiction treatment and recovery, process, mechanisms of behavior change, and reducing stigma and discrimination among individuals suffering from addiction. So with that, John, please take it away.
Thanks, James. Just share my screen with you. Hopefully you can all see that okay. Thank you. We're almost here at the end now of fairly intense afternoon, and thank you for hanging in there with us. A lot of information. I have felt just you know, a kind of a powerful, potent overview in many different aspects of COVID-19 and its impact on addiction and kind of allied mental health issues related, which often go along, of course, with addiction. So I'm going to kind of try my best to provide some overview, summary, some synthesis, and some thoughts, and then we can hopefully have a few minutes of discussion and Q&A with James and myself, and perhaps Dr. Koob if he's still around. It's complicated, I think, is the thing that James and I were talking about a little bit earlier. Just in thinking through some of the data points that have been gathered regarding, as we've all kind of scurried to understand in real time, what is the impact of COVID? We're kind of trying to build an airplane while it's flying. That's been the experience, hasn't it, of really tackling this severe problem with coronavirus as it's infiltrated the country and the world. And I think the general public perception, perhaps even my own perception implicitly, is that, well, substance use would have gone up, right? It would have all gone up, and we've all gotten stressed because that's the nature of things. So I think, you know, left unscrutinized and untended, that assumption might be pervasive and carry through without further examination, because I think it's kind of natural to think about social isolation and COVID and all the things that that induced as being stressful, which of course it was for many. Whether that and how that affected substance use, both in terms of onset, the course, and recovery and offset, has been an interesting question that we've been privileged to see today in terms of how things seem to have unfolded. And I think what we have seen today across these different talks, expert talks, is, interest, looking at the etiology, the effect of teenage use and drug use, Dr. Volkow mentioned, and how the impact of COVID really highlighted in more stark relief the powerful influence of social contexts in drug use. And Dr. Mckellap also emphasized this with his work that he showed on young adults. Other epidemiological factors, both in terms of onset of use, clinical course, the different pathways into, through, and out the other side of substance use disorder and its clinical course, as well as, of course, treatment and recovery and the impact that COVID has had on access to treatment and recovery support services and all that, what that has meant both for individuals as well as policy changes and reimbursement changes. That's been very important to change as COVID has come and stayed longer than we would have liked. It's complicated, it's nuanced, and I think we've been privileged to have kind of two countries, of course, involved here in North America, Canada and the United States. But Dr. Mckellap also showed us some other global data, epidemiological data regarding the impact of COVID in terms of infections and deaths. And you can see very different impacts around the world, depending on where you live. So that, of course, naturally indicates there are different factors, different contextual factors, which affect these infection rates and the impact that it's had on substance use and mental health. So we've seen these modulators or moderators across international boundaries. We've also seen it across the life course, across different talks today, in terms of its impact on teenagers, on young adults, on adults and older adults, and across different dimensions in terms of physical biology, as well as psychological, emotional factors, and social determinants, which can affect health. I don't think, when we think about mental health and addiction, we tend, at least I don't always think about the direct effect of coronavirus on susceptibility to contraction. That's not what I first think of. And I think most people probably think of the stresses, again, induced by COVID resulting in substance use. But for those with substance use disorder themselves, we have seen how people with those conditions, perhaps through compromised immune deficiencies related to substance use, are more likely to contract the virus and suffer COVID with a higher degree of disease burden, which I think is something that doesn't readily come to mind, but it's something that's very important when we consider the impact of COVID at the biological, medical level, that people are just with more compromised immune systems are more vulnerable to contraction and greater disease burden. I think we also saw today the impact of different moderators or modulators of the effects. In terms of alcohol and opioids and cannabis, different effects for different primary substance use. The intersection also of substance use disorder in the context of COVID, with age, with sex. Dr. Koob demonstrated the rise among women, for example, in terms of adverse impacts, in particular liver disease. Race and ethnicity, we saw that starkly contrasted, starkly emphasized regarding different groups, particularly Black and African American and American Indian and Alaska Natives being particularly hard hit by overdose in the context of COVID, as well as deaths from COVID. I think also what was highlighted for me was different risk and protective factors associated with life course developmental risk for the onset of alcohol and drug involvement, as well as substance use disorder onset and exacerbation, as well as recovery. And of course, this highlights the social environmental context in which drug use occurs, with the start of drug use, how that is incubated among social groups, so that it becomes, it can turn into cases, of course, diagnostic cases, but also on the other side, as people get into treatment and recovery, how important the social environmental contexts are for that. And both of those have been impacted, one arguably on the favorable side in terms of reducing occasion of exposure among teenagers who ideally should not be exposed, developing brains should not be exposed to these substances. So that's had a kind of a salutary effect on onset, but it has a detrimental effect on offset on the other side in terms of access to recovery support networks, which can be so important for many people who have been severely affected by addiction. And I think, you know, from a kind of the services side, the services provision and policy side, as Rita, Nora, Andrea really highlighted for us today, that COVID has exposed cracks and holes in the healthcare systems, both in the United States and in Canada, as well as policies governing how we can respond more nimbly and effectively to substance use disorder. I think it amplified substance use disorder specific public health challenges around restrictive access, particularly for medications in community, clinical, and criminal justice settings. That predated COVID and highlighted opportunities for change that has resulted actually in policy and legislative changes in provision and practices, which has been, I think, incredibly welcome, that can help save lives. For example, it stimulated new legislation to address decriminalization, as Dr. Notarandrea mentioned, as well as broad clinically focused harm reduction efforts in terms of overdose prevention sites, safe supply and accessibility to naloxone and medications for opioid use disorder. As we've seen these dramatic increases year on year through COVID. And in the United States, Dr. Delphin-Rittmon really highlighted some very significant policy, legislative, health services changes in, again, provisions and practice around medications and access to medications, as well as other services that can help people who suffer from these conditions. Some very significant loosening of restrictions on practices for prescribing, for example, in terms of access to and flexible access to medications. Greater availability and accessibility to naloxone in different formulations, and fentanyl test strips, being able to use federal funds to be able to buy fentanyl test strips, for example, has been a major change, which has happened last year. And as she pointed out, I think very importantly, the ability to more readily attain a license to be able to provide mobile medication availability through mobile units, to go to where it is needed, to take the medicine to where it is needed on the front lines, as it were, has been, life-saving for many people and a real innovation which hopefully will remain. The removal of buprenorphine training requirements for prescribers. Ironically, physicians and other medical professionals can prescribe opioids without any specific training. They can even prescribe buprenorphine for pain without any specific training, but you could not prescribe buprenorphine for opioid use disorder, interestingly. So that has changed, so that has been removed, so that medical practitioners can actually prescribe buprenorphine for opioid use disorder specifically, which can then increase availability and accessibility for more people who need access to medications. There's also been a shift in the relative emphasis with more urgent attention across the network of training, education, and support across different systems sponsored by the federal government, both in Canada and the United States. And then also the permissibility and payment of telehealth that is for counseling and psychiatry. And I think, in Canada, Rita Notarandrea really highlighted kind of some top priorities there, which need to be implemented, have been implemented, and are underway or under scrutiny for vote in the legislature, in Parliament in Canada, regarding decriminalization, for example, for non-criminal penalties for possession of small amounts of currently illicit substances, which, in my opinion, does not help the situation, but rather diminishes the chances that people can get a building permit to on the other side, to be able to get back into real life. She also mentioned other issues of overdose prevention sites, providing that and safe supply, as well as something else we don't often think about, which is the health care workforce itself and the impact of COVID on the health care workers, just how stressed out they have been, and the kind of secondary trauma that she mentioned regarding just seeing so many people overdose and die as a frontline worker unnecessarily, and feeling that sense of I could have done something, we could have done something to prevent this death, and we were unable to do it. And that happening over and over can be obviously very draining, disheartening, and frustrating. And also, and this is of course related, which is the physician burnout studies, as well as the fact that personal protective equipment was not available to mental health and substance use disorder workers, as they were not deemed to be essential workers, which really is a form of discrimination which we're faced with in the addiction field all the time. And here's just an example that I use in talks when I give talks on stigma. But here's just one example. I ask people, this is slightly rhetorical, but I'm not going to give you much time to look at these pictures, but we often see these "I'm not a robot" things when we're asked to sign things or enter things on online resources. But see if you can correctly identify all the pictures which feature addiction treatment facilities and which treat other kinds of health conditions. If I were to give you a few moments, you'd be able to see, I think, quite accurately which particular facilities are treating addiction patients and which are treating other kinds of health conditions. And there is a stark, unfortunately, and easily observable stark difference. Now, why is that? It's because, I think there's a societal view that people with addiction and mental health, they're second-class citizens, they're second-class illnesses. They're not real diseases. They don't deserve real high-quality services or real high-quality environments. I think we need to pay attention to what messages is sent when we treat people in diminished, dilapidated buildings, which are obviously second-rate compared to other kinds of health facilities. Is it good enough for, quote, addicts? Is that good enough? And I think that is something that is just a marker, an indicator for me of the type of discrimination across healthcare and society that we face in the addiction field. So just a few final thoughts before we open it up for questions. A couple of thoughts. One that came to me was, can we address substance use disorder like we addressed COVID? It was remarkable, wasn't it, how quickly the nation and the world came together to focus and develop effective vaccines with unprecedented speed. Never in the history of humankind have we been able to get vaccines so quickly as we did with COVID. Think about that level of urgency, which is not there when we're addressing the hundreds of thousands of deaths which are caused by substance use, opioid and alcohol in particular, every year. How many more families have to be bereaved from alcohol and other drugs before the same level of urgency can be applied to address substance use disorder? do we have the will to build and increase and invest in our clinical and public health infrastructure to address substance use disorder the way that we have so readily done in the face of COVID? For example, real-time epidemiological surveillance and data capture, not to criminalize individuals, but to enable and facilitate root cause analysis and more timely clinical and public health intervention, and more impactful and better informed and more specific prevention in the communities which are particularly highly impacted by overdose deaths, for example. Imagine if we had that same level of surveillance so that we could really be much more nimble and learn a lot more from the causes and contexts in which these things occur. So again, I think there is obviously, in the last 2 years, addiction has been on the front burner, as it were, in terms of our cultural front burner mindset. Every day in the media, we've been hearing about overdose. Now it's been somewhat clouded by COVID, but it's been present, it's been there, and yet we still have not had the same degree of infrastructure building around this, which I think needs to happen. I'll stop there, James, and we can open it up for questions. Thanks, everybody.
Great comments, Sean. Really insightful. Hazel, do we have questions from the audience?
I don't see any questions right now, but everybody, now that it's the final discussion period, you can either feel free to click the raise hand button at the bottom and we'll unmute you and then you can ask your question to the speakers, or you can continue to type questions if you prefer to do that.
I see Dr. Koob has a question.
Yeah, so I have a question for the Canadian side. Maybe you, James. Given that you have universal healthcare, you do, don't you?
We do.
What would you say was the benefits and maybe the drawbacks compared to the American system throughout given this past 2 years, vis-a-vis substance use disorders, including alcohol, of course? I mean, I suspect there were some advantages, but I suspect there may have been some disadvantages as well. And I'd be curious to hear what you think.
Yeah. So for Americans at the summit who may not understand the Canadian healthcare system, there is universal healthcare in Canada. It is administered by the provinces and territories, so it does vary from jurisdiction to jurisdiction. I think that in some ways, the principal, one unseen advantage is that it in many ways provides a lot more primary care and preventive care to address many of the chronic health conditions that set people up to have adverse reactions to COVID-19. And so I think that that's one of the kind of unseen but very relevant factors. I think the other consideration is that there are fewer barriers to accessing care, in the sense that I think the uninsured or the underinsured are more likely in the US to not seek care until it's absolutely essential, at which point in this case, the virus may have really progressed to a more serious level. I think in the context of alcohol and other substance use disorders, care is covered, but many of the same challenges pertain. And I think that John touched on a lot of these issues, in that the reality is everywhere there is stigma hiding in plain sight, in the way that treatment for substance use disorders does not happen in the same kinds of settings and within the traditional or the more conventional precincts of medicine. It's often in community settings that are not as well equipped, or don't necessarily have the same expectations around patient respect or services. And I think that there are some surprising disparities too. You would imagine that there would be easier access to evidence-based interventions like naltrexone or acamprosate, and yet we still see that the rates of utilization are really troublingly low. And so I think that on the one hand, there is much to be gained from a universal healthcare system in the context of a pandemic, when you have this vast ubiquitous health issue. On the other hand, it is not a panacea. It will not solve the problem, and many of the realities are still there. As hospitals fill up, just because you have universal healthcare doesn't mean you have more ICU beds. When you run out of ICU beds, you run out of ICU beds. And I think that the challenge with the pandemic has been, in some ways, challenges with asymptote. When enough people get infected, systems reach breaking points, and that's where there's really excess morbidity and mortality. And the Canadian system has suffered from that similarly during the most virulent waves. So I think that in some ways it has offered some significant benefits. In other ways, it has faced the same challenges. One interesting difference that is in contrast to the deaths of despair that you raised in your talk is that there haven't been the same rates. There hasn't been a parallel pattern of deaths of despair in Canada relative to the United States, which I think is a very interesting feature as an American living in Canada. And I think that in some ways, the absence of access to health services in the US has unfortunately been part of the unseen causes of those high rates of middle-aged and male excess deaths.
Yeah, no, I hear you. I mean, it's like parity is trumped by stigma in Canada, whereas parity is trumped by insurance in the United States, but the same result, which is, and it's just I try to think of what can we do, and one of the things we're really working hard on is to try and decrease the treatment gap, which a number of the speakers, almost everybody at some point mentioned at some level, and so I just want you all to know, from my perspective, anybody that has any good ideas on how to, we have some ideas of our own that we're implementing, but how to reduce the treatment gap. I mean, even where you have universal health care, you have a treatment gap when it comes to addiction in general. I'm just talking in general. So I'll shut up and see if anybody else has come up with some questions in the meantime.
So we have a question here from Gladys, and she says, you commented on the impact of COVID-19 on healthcare provider burnout. Is there data on substance use disorder among healthcare providers during the pandemic?
There is an alcohol study that shows that I don't have it in front of me, but that clinicians increase their alcohol, who were suffering burnout, increase their alcohol intake significantly. There is at least one study out there. So, I mean, I don't think it matters what your profession is. If you're suffering from burnout, there's going to be a subgroup of people that are going to use alcohol to self-medicate. Yeah. Not everybody. I just said a subgroup. Okay, yeah. I want to make that clear.
Yeah, my first thought was, healthcare SUD professionals are people too, and susceptible to the same kinds of things, stresses, and you might even see that same third, as George mentioned, other people mentioned that maybe a third went up, a third stayed the same, a third went down. But undoubtedly, it would be probably a portion of those that increased.
Since I'm old and I can remember things, fentanyl's been around for a very, very long time. Most of you know it's used for epidurals, and it was made by Janssen Pharmaceuticals. And before the opioid crisis, which probably was triggered to a large extent by the oxycodone story that most of you are familiar with, one of the highest groups of misuse of opioids were anesthesiologists who had access to fentanyl, just for the record, okay? And I know a lot of anesthesiologists, and most of them can tell you about someone, this is long before the opioid crisis broke, they could tell me about someone in their medical school class or their residency who had actually gotten into trouble with opiates because they had access to them as anesthesiologists.
George, to your point about the kind of evidence to implementation gap, I do feel like the field is somewhat underserved in terms of health services research on strategies to get technologies into clinicians' hands and to motivate and incentivize, evidence-based strategies. And I think that this is one of those perennial challenges and a great frustration for researchers who are, who can kind of see what works and then see that in all of the settings around them, it's not being used. And I think that I'm not sure what the answer is. Years ago, we were developing a project to think about contingency management for clinicians to use evidence-based practices. But I think that, these are the kinds of challenges we have in that the literature won't do the treating, right? The literature has to be in the hands of healthcare professionals who want to use new techniques and do so.
I couldn't agree more. I mean, this is the challenge I've taken on for NIAAA for the last 2 years, which is to get even broader, get evidence-based information out to the real world. And some of you know we have an NIAAA treatment navigator. We have a website that's pretty popular called Rethinking Drinking. We put out College Aim for college campuses, which are a menu of prevention options. We're working on what we call a clinical core resource. It'll have a better name, but it's almost done, which will be 14, units of information that go out to clinicians, everyone from a nurse practitioner, clinical psychologist, physician's assistant, primary care doc, all the way to a board certified addiction medicine specialist on what you should know about alcohol. But what you raise is a really important, and we are trying to, at NIAAA with our resources, we're trying to expand our health services portfolio. But you just touched on something even more important, which is there are behavioral therapies. There are probably, there's certainly medications that are grossly underutilized in addiction in general, and alcohol field in particular. And we need to find a better way to get these out to the real world, to the people who can use them and use them effectively. So it's a big challenge, but I wrote down what you said. So, what are the technologies that we could get out to people? What are the prevention mechanisms, methods, and paradigms that have actually worked? And they're out there. But we got to get. I hate to say this, but in the United States, I suspect that middle schools are still using the DARE program.
It's true.
Which I don't believe there's any evidence-based information that that's effective. So.
I would imagine that in Canada with the national healthcare system, as James mentioned, there's a greater incentive to push out and more requirements for clinical providers to kind of have performance measures as part of their protocol to make sure that they implement evidence-based practices the way that's done in the United States in the VA system, which is, you know, the biggest healthcare system in the world. I worked in the VA for quite a long time, and saw how that worked as a national healthcare system for veterans. And it was, you know, in many ways, they're a leader in the United States of how to, you know, bridge this implementation, you know, efficacy to or effectiveness to implementation gap, because they had a whole arm, which I was privileged to work in, of quality enhancement, which was designed for this explicit purpose to help the system in various vicinities to be able to identify gaps in evidence-based practice and help them adopt and implement and sustain. Of course, related to that implementation effort. But that's only part of the problem, isn't it? Because it's implementing kind of best practices, but also how do we attract and engage people? There's only 10% of people actually access any kind of service for an SUD. Now, it tends to be the people who are hurting the most, naturally, because they're the ones that are most motivated to get help, those who are more severely impacted. And you have most of the cases being mild and moderate, but that large population accounts for the largest proportion of the burden of disease and disability and economic impact. And so it's how can we engage and attract and engage more of those individuals into some kind of quote unquote treatment. I use it in quotes because I think maybe that's a barrier when people think about having to get treatment. I think our cultural default is kind of, well, if I've got an alcohol problem, then that means I've got to go to rehab, right? That means rehab and AA or rehab and something. That's our cultural default when we think of alcohol or drug problems. But I think people are not aware of myriad other things that they can do. And I think here's an opportunity in the face of COVID relating to telehealth, is all of these online programs that have been developed for self-screening, appraisal, to get a look at how one is using a substance, and then being able to do something about it. Someone mentioned earlier, I forget, it might have been you, George, about CBT for CBT, computerized cognitive behavioral therapy, other interventions that can be delivered via a computer at home, but also other kinds of things that can attract and engage people to achieve health, behavioral health. The metaphor I'm using recently is fitness centers. And so, the question is, do fitness centers keep people fit? Of course, the answer is yes, they do, but you've got to go to the fitness center,
right?
And you've got to work out, right? Now, fitness centers are clever because they don't just have a weight room. They don't just have a weight room, a free weight room, and that's it. They've got all kinds of classes. They've got pools. They've got courts. They've got all kinds of facilities to attract and engage more people, to engage in some kind of activity which will enable them to become physically fit. And I think our repertoire, if we make that analogy to kind of fit for recovery or fit for behavioral health, we've been a bit like we've been providing maybe a weight room and something else, but not much else. And increasing the options, the things that are like, and I think we have to be a bit innovative here. One example that comes to mind for me is Phoenix, the Phoenix, which is a physical activity operation run by peers in the community. It was started by someone who got into exercise as a way to overcome their addiction. And they found other people to do that with, and they created this network, which has grown nationally. And I think it can attract and engage people in kind of not quote unquote sitting around in groups doing CBT kind of treatment, but actually hanging around, being exposed to peers in recovery, doing fun things, which can compete with alcohol and drug use in a rewarding way. And that kind of thing, to me, we need more options like that. We need to think a little bit outside of the box from a broader public health perspective that can attract and engage more people in different kinds of things that can achieve the same developmental outcome, in this case, remission, maybe for the mild and more moderate cases.
Yeah, no, I couldn't agree more with everything you said myself. Tom McClellan, Nora, and I have been, and another lady have been working on an idea of Tom's about, attacking this mild to moderate addiction, as you guys term it. And I think you all know Tom McClellan originally from the University of Pennsylvania, supposedly retired, but he's clearly not completely retired. So, I think this is an area really to be addressed, and those are some great ideas. I like the fitness center analogy.
John, I'm glad to hear you raising, positive, salutary interactions with peers and the development of mutually competing alternative reinforcement. And I think that, I see a comment in the chat that there's someone starting a wellness center with tribal practices, healing and revitalizing tribal connections. And I think that, one of the things that we talk about here in our treatment programs is how not drinking is just one part of recovery. But another huge part of recovery is establishing all the other psychosocial activities that are part of functional recovery, that, employment, relationships, housing, and meaningful recreational activities that are how you find meaning and pleasure and joy. And I think that, one of the things that the pandemic deprive people of were all those alternative reinforcers as one possible mechanism for where we do see those upticks in substance use. And I think that it's a reminder that any fulsome portfolio of research on changing substance use behavior has to include alternative reinforcers. I'm always very inspired by my collaborator Jim Murphy's interventions, the substance-free alternative reinforcer interventions for young adults, but I think that they apply to regular adults also in the form of the community reinforcement approach. And I think that more generally, I have been reminded during COVID of how critical it is to prioritize or to think about alternative reinforcers as the pathway to long-term recovery.
I think those are really good points. I've always thought that a community reinforcement approach is, I guess it goes to my days when I was on the advisory board at Penn with Chuck O'Brien and George Woody and Tom McClellan, because that's the approach that they championed there in Philadelphia, and I think it was pretty effective actually in their community at least.
Got any more, I see some bubbles in the chat there. Is there more chat or questions, Hazel?
There are no more questions, just a few comments from people. But I think that's it for questions for now.
Okay.
Well, this has been a very stimulating and I think illuminating day. And I certainly feel like it has been an opportunity to step back from being in the trenches and think hard about the bigger picture issues. John, would you like to offer any final comments?
No, I agree. I just, I'm glad we've got this because there's a lot to grasp here. And I think over the next several months, as we ponder on all the things that have been learned and documented so far. But of course, a lot of this is still emerging, and we're going to learn a lot over the next years of the impact from this, because I think for me, it's presented things more in stark relief. It's accentuated certain things that really have become clearer in the face of COVID, which has actually done us some favors. And this has been the kind of silver lining of COVID, the lessons we are learning and have learned. So I'm hopeful that we can, build on this and move this forward. So I'm just grateful for everybody taking the time. Dr. Koob, thanks so much for hanging in for the whole afternoon. Really grateful that you were able to stay and contribute continually through the afternoon. It's great to have your perspective, and also to have this, documented, recorded as well, so that people can view it later. Dr. Koob, did you have any other comments?
No, I just thank you both, all of you, not just you two, but everyone who participated. I learned a lot, and I really enjoyed our last discussion, because I think I always need new perspectives and new look at things, but often what I learned today confirmed a lot of the things that I felt in my gut, I guess is what I want to say. But sometimes I'm not able to express it in a coherent way. You guys, you all today, everyone, had a different piece of the puzzle, but I learned a lot. So thank you.
Thank you so much for participating.
Thanks, George.
This has been
Yeah.
great. Thank you, everyone.
Goodbye.
Right. Good night. Good night, George. Have a good
Stay
weekend.
safe,
Thank you.
everybody.